Good morning, everybody. My name is Laura Carroll. I'm the president of the Medical Services Board meeting. Welcome to our December 2025 edition of the Medical Services Board. Mr. Sykes, would you please help me with roll call?
Certainly. This is Chris Sykes. Laura Carroll.
Present. Good morning.
J.K. Costello. Present. Morgan Honey.
Present.
Amanda Jaslinski.
Present.
William Kennard.
Excused.
Barry Martin.
Present.
Kasana Littler.
Present.
James McLaughlin.
Present.
Christina Mulkey.
Here.
And David Pump.
I can see him. I think we're having an audio issue with Mr. Pump. David, are you able to put in a comment to make sure you can hear us? Oh, what do I got here? Well, that does give us a quorum. Is that correct, Mr. Sykes?
This is Chris Sykes. Yes, Madam President, we do have a quorum.
Okay, we're going to proceed. David, if you're having tech issues, please reach out to Kelly. You know that he is the genie of all these things, and he can fix whatever isn't working. He's done it for me. All righty, team. With that, we are going to go for an approval of our November minutes. May I have a motion to approve those minutes, please?
This is Morgan Honey. I'll approve those minutes. Motion.
Thank you. Thank you, Morgan. May I have a second, please?
Barry Martin,
This is
second.
All right, thank you. All in favor?
Aye.
Aye.
All opposed? Excellent. I changed up the order a little bit, guys. I wanted to get that out of the way and then go on to announcements. We've got kind of a wild day going on, and that just made more sense for the way that I wanted to present things to y'all. Okay. So on to announcements. The location of the next Medical Services Board meeting is scheduled to be held Friday, January 9th, 2026. Can't believe that. Beginning at 9 a.m. virtually and in person in 303 East 17th Avenue, Suite 1100, Denver, Colorado 80203. If you are listening via audio stream and lose the connection, please click again on the link to rejoin the meeting. Closed captioning is available on your Zoom toolbar, and staff will chat out instructions. Please identify yourself when speaking comments, as they are part of the public record. It is the responsibility of the Medical Services Board to adopt the rules that govern the department's programs through consideration of stakeholder input in alignment with the department's mission and in the best interest of Coloradans. There is testimony sign up for the open forum and for each rule. If you need help finding the rule in which you are interested, please ask staff for help. Please keep your testimony related to the rule being discussed. Public comment today will be limited to 2 minutes. At the end of 2 minutes, your time will be up, and we will move on to the next individual signed up to testify. And I want to take a moment to talk about what we are going to look like with both testimony and our layout today. We have got a wild and woolly meeting with a lot of interesting things going on, so it's going to look a little different. First, I want to talk about the emergency rules versus final adoption rules that you'll see first this morning. We have a couple of rules that will both be on emergency adoption and on final adoption this month. I like to take a moment to remind people that these are two completely different processes. Emergency rules give us the opportunity to get something into play right away with a 90-day cutoff, while we have the opportunity to do what we need to do to get our other rules into place. So that is why we see that. There were a couple of these rules that came into play between election and HR 1 and all of the things in between. So what we're going to do with those two rules is we're going to have one reading, both for the emergency rule and for final adoption. We will allow comment on them as a coupling, and then we will take a motion and pass first for the emergency and then for final adoption. So that's the first thing I want people to understand. The next thing going on, and I'm sure you are all acutely aware that we have document 9 on our emergency agenda today, which has, let's say, very robust feelings and opinions attached to it. I have not looked at the list in the last 20 minutes, but we had something like 60 people signed up for public testimony. Is that about right, Mr. Sykes?
This is Chris Sykes. Yes, you are correct, Madam President.
Okay. Could you all just even imagine? I have been trying to find the very best way for all of us to get as much information through to each other as possible, and this is what I am proposing. First of all, we have moved this emergency adoption to the end of the meeting so that all of the other things that need to get done can be done in a timely and professional manner, and that we allow adequate time for this rule to be properly discussed. There is no way in the world that we're going to get through 60 people talking for 2 minutes each. My team are a group of volunteers. I am not going to even put them through that. This is what we are going to do. We have noticed that there are organizations that have as many as 20 people signed up to give testimony during document 9. What I'm going to do is I'm going to call on first one person from that organization, and I'm going to have their 2-minute statement given. At that point, I'm going to ask the other folks, I'm going to let them give their name, state who they're with, and I'm going to ask them if they just want to ditto what is said by the first person or if they have anything to add. I'm going to keep a very tight rein on this. We do not have time for repetition, and I really want every single point heard, and I want to make sure that everybody's name and affiliation gets read into the record. This seemed to me to be the fairest and best way to make that happen. I am telling you guys this ahead of time in case you have somebody in your organization who's really your most favorite that you like to give the talk first. That way you can put your most powerful foot forward. I am in gratitude to my medical services board, to HCPF, and to all of the people who have shown up today. I enjoy me some good debate. I am really actually quite looking forward to this, but I want to make sure everybody has fair time. And with that, ladies and gentlemen, that is announcements, and we are going to go on first with final adoption by consent. May I please have somebody make a motion for that?
This is Morgan. I can do that, Laura.
Thank you, Morgan.
I move the final adoption of document 01 MSB 25-08-14-A, revision to the Medical Assistance Act rule concerning audit and child respite, sections 8.7545 and 8.7546, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you. May I have a second?
This
Barry
is Amanda,
Martin,
I
I'll
second.
Mr. Sykes, would you call out somebody in the room for me, please?
That was Dr. Jaslinski who had initially seconded ahead of.
Thank you very
Dr.
much. All in favor, please say aye.
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 Aye. All opposed? Abstentions? Wonderful. Thank you very much, team. We are on to part 1 of the emergency rules adoption for today. And we are going to start with document 6 and Corey Conalog. Good morning, Corey.
Good morning, Madam President. This is Corey Conalog, and I am the Pharmacy Policy Specialist for the department. I am presenting document 6, MSB 25-10-20-A, revision to the Medical Assistance Act concerning enhanced dispensing fee correction for parenteral nutrition, section 8.800.13.p. So in October, MSB approved the rule establishing an enhanced dispensing fee for parenteral nutrition. Just to recap, parenteral nutrition requires a highly specialized individual preparation of the formulas, and that current dispensing fees don't adequately support that. Senate Bill 25-084 authorized an enhanced dispensing fee to ensure that pharmacies can continue to provide this critical therapy and maintain member access. The implementation of this policy also required a state plan amendment with the federal government. MSB approved our initially proposed rate of $70.76, but days later, CMS approved a higher rate of $73.21. After final adoption in October, during the state plan amendment approval process, CMS asked us to use a different methodology to calculate our enhanced dispensing fee rate. Myers and Stauffer, an actuarial firm, conducted this revised analysis using the same data and this resulted in an increase of $2.45 per prescription fill, which CMS then approved. And therefore, this rule change updates the rate approved in October to match the state plan authority. An emergency rule is required to comply with the federal authority granted under the CMS approved state plan. The updated enhanced dispensing fee must be implemented with the statutory effective date of January 1st, 2026 to maintain compliance with CMS approved reimbursement rates. So although the state budget crisis does persist, the budget impact of this rate increase is expected to be quite minor. We've received positive stakeholder feedback on this emergency rule, and we haven't received any questions or concerns. I kindly ask for a yes vote to ensure that reimbursement is consistent with the CMS approved state plan by the statutory effective date of January 1st, but I will happily answer any questions.
Sorry about that. I didn't realize I had muted. Thank you, Corey. Do I have any questions from the board?
This is Cassie Littler, Madam President.
Good morning. Go ahead.
I just wondered if this rate rule is reviewed by MPRAC or if this has to be in the rules here.
This is not in MPAC, but it is something that we are including in the rules. It is a section that we added back in October, 8.800.13.p. And since we listed the rate when we established the rule, we have to change it when it changes.
Great. I just wondered how this gets updated going further. If we have a specific rate in the rules today, do we have to then bring it back to rules every time CMS increases the rate? Or if that's reviewed by MPRAC, that was my question, I guess. So.
Sure. Our dispensing fee process is, or our rate setting process is done by survey. So we use actual data. That survey is done periodically about every 5 years. And so it's not a rate that's updated very frequently, but it is a rate that we include in our rules. All of our dispensing fees we include in our rules.
Thank you.
Madam President, this is Chris Sykes. Just for the record, I want to point out that MPRAC is the Medicaid Provider Rate Review Advisory Committee.
I am in gratitude for you calling out those acronyms. I also saw that Rachel had popped that into the chat for us also. I sit in gratitude to everybody who helps us wade through the alphabet soup of this business. And yes, thank you very much, team. Any other questions for the board? From the board?
Madam Chair, this is James McLaughlin.
Good morning, James. Go ahead.
Thank you, Madam Chair. Just continuing that same vein, I would like a little more clarification on the value of having it go through this process versus changing it in the rules to have it go through MPRAC like everything else. Because it does seem, and maybe I'm just ignorant to it, and that's what I'm asking for, is if you could help me better understand why it's better for that to go through this process versus changing it in rules to go through the MPRAC.
This is Corey Connell again. That particular question, why it's done this way, is a little bit outside of my particular wheelhouse. I don't have my supervisor here on the line with me today, but I can, if anybody else can step in for me from the department, or I can come back and give you that more robust when I come back for the initial adoption of this rule rather than the emergency adoption.
Madam President, this is Rachel Entrican, if I may.
You may always.
Thank you. This is Rachel Entrican, Legal Division Director for Healthcare Policy and Financing. And Corey, I think just to jump in here, not every rate is required to go through the MPRAC process. So that's why we're seeing some that do and some that don't.
Thank you,
Thanks,
Rachel.
Madam Chair, that works.
Great. Thanks,
Sorry,
James. Appreciate you. No, that's okay. I appreciate you keeping it rolling with me. Any other questions from the board? Hearing none. Mr. Sykes, do we have anyone signed up for public testimony on document 6?
This is Chris Sykes. We do not have anybody signed up for testimony on document 6.
With that, I will accept a motion on document 6.
I can take that, Laura.
Thank you, Morgan.
I move that all this is Morgan Honey. I move that all emergency rules that are adopted include a finding that their immediate adoption is imperatively necessary to comply with state or federal law or federal regulation, or for the preservation of public health, safety, or welfare, and the compliance with CRS 24-4-103 would be contrary to the public interest. I move the emergency adoption of document 06 MSB 25-10-20-A, revision to the Medical Assistance Act concerning enhanced dispensing fee correction for parenteral nutrition, section 8.800.13.p, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you, Mr. Honey. May I have a second, please?
This is James McLaughlin. I can second that.
Thank you, Mr. McLaughlin. All in favor, please say aye.
Aye.
All opposed? Abstentions? Lovely. Document 6 passes. We are
Chair,
on to,
Laura,
yes. Yes, Morgan.
Point of order.
Sorry.
So since we broke up the emergency adoption agenda, when we come back at the end, do we need to reread the emergency adoption rules paragraph for whoever may be on base for that?
If that is a quick answer, we can get that now. Otherwise, I will make sure I have it by the time we have second emergency. Do we have a
Works
quick
for me.
answer, Mr. Sykes?
This is Chris Sykes. We do. No, it does not need to be read again.
Great. Thank you so much. I appreciate you. All right, team, we are on to, this is one of the first ones that we're going to kind of show two at once. We are going to be talking about both documents 7 and document 2. And we have Tracy Gonzalez with us this morning. Good morning, Tracy.
Good morning, Madam President. Good morning, also members of the board. My name is Tracy Gonzalez. I am the Finance Unit Administrator in the Special Financing Division. Today I'll be presenting Document 7, MSB 25-11-28-A, the Provider Stabilization Fund. I'm also joined by Daniel Harper, the Finance Unit Manager, who will assist with any questions that you may have. Next slide, please. Senate Bill 25-290, which was signed on May 28, 2025, created the Provider Stabilization Fund. The bill intends to provide much-needed short-term stabilization funding to eligible safety net providers that serve low-income uninsured patients in the state. It also seeks to alleviate the financial burden caused by the Medicaid unwind and the growing number of uninsured individuals across the state. Next slide, please. There are 4 types of eligible providers for 4 provider types are eligible to apply for support under the Provider Stabilization Fund. They are comprehensive community behavioral health providers, rural health clinics, federally qualified health centers, and healthcare providers delivering primary care services with at least 50% of their caseload consisting of individuals enrolled in Medicaid, Medicare, CHP Plus, or individuals who are low income and uninsured. Next slide, please. To qualify for funding, providers must meet one of the eligible safety net provider conditions. They must complete an intent to participate and submit a completed Provider Stabilization Fund application or an attestation form that they will be using the primary care fund application numbers. Next slide, please. Funding will be allocated to agencies based on the number of eligible patients seen during the calendar year. An eligible patient is a low-income, uninsured individual whose family household is at or below 200% of the federal poverty level, who are not enrolled in Medicare, Medicaid, or CHP Plus, and who have no third-party paying or reimbursing the provider for all or a portion of the amount charged for services. Next slide, please. The Provider Stabilization Fund consists of money credited to the fund from the Unclaimed Property Trust Fund, as well as gifts, grants, and donations that may be received from public or private sectors. Payments shall be based on the individual safety net provider's number of eligible patients in an amount proportional to the total number of eligible patients served by all safety net providers. Next slide, please. We revised the definition of primary care to align with existing primary care definitions. The new definition is here on the slide. I will not read it just for time purposes. Next slide, please. I am presenting this as an emergency rule today to ensure that there is no gap in regulation prior to the permanent rule adoption on February 13th. Last slide, please. Thank you for your time and consideration at this point. We will be happy to answer any questions that you might have.
Thank you, Tracy. Do you have any questions from the board?
This is Kathy Littler. I have a couple of questions.
I hear you. Go on ahead.
First is a question about the unduplicated user or patient. And the part of the rule that says that the sum that is provided to the safety net provider does not include counting a patient more than once, but payment source changed during the applicable calendar year. So I worry about as we have concerns about the tax credits going away, people becoming uninsured in large droves, maybe cover all Coloradans, worry about that. If there's large drops in coverage for particularly children, if there's a way to monitor that so that if there's big changes in a calendar year, that could be accounted for. So safety net providers don't lose out for a full year when their patients become uninsured.
This is Tracy Gonzalez speaking. So payments are based on the prior year's numbers. So we are taking the patient's last visit closest to what the clinics would choose as a free state, which could be at the end of the applicable calendar year, so December 31st. And for this grant period that we are in, we are looking at calendar year 2024 patients. So we are looking only at the patient's last visit closest to December 31st, or they can use up until the application due date, which is in May, so May 25th. So if their insurance determination did change during that calendar year, it is going to be notated at that last appointment closest to the end of the applicable calendar year.
Thank you for that, Madam President. This is Cassie Littler speaking. I guess my concern is then for the next year, there could be huge drop-offs, right? And so would that be taken into account?
So this is Tracy Gonzalez speaking again. So for this grant cycle, which is the grant cycle 2025-26, we will not be looking at any patients that are seen during this calendar year until the next grant cycle, which will be 26-27. So we will strictly be looking at the prior year's patients each new grant cycle.
Thank you for that.
Did that answer your question?
Yes.
Awesome. Thank you. Any other questions from the board?
Madam Chair, this is JK.
Good morning, JK. Go ahead.
All right, Ms. Gonzalez, Mr. Harper. There are two types of safety net provider in behavioral health. There's comprehensive safety net provider and there's essential safety net provider. And I know that only one of those is covered under their provider stabilization fund. Essential to me means they're necessary and therefore may be eligible for something like provider stabilization funds, yet they're explicitly not eligible. Can you explain that, please?
Hi,
Tracy?
this is Daniel Harper. Can you repeat the first part of the question? I just want to make sure I heard it fully to be able to answer.
Sure. There are two types of licensure for safety net providers in behavioral health. There's comprehensive and there's essential. Yet only comprehensive providers are included in this provider stabilization fund.
Okay. I guess a follow-up. This is Daniel Harper, and a quick follow-up question for you for clarity for me. The two different safety net provider types that you listed, do they both provide primary care services, in which case they would both be eligible under that fourth provider type where they are providers providing primary care services with at least 50% of their patients' caseload consisting of individuals enrolled in Medicaid, Medicare, CHP plus, or who are low income and uninsured.
Madam Chair, permission to speak.
Go ahead.
That's a good question. 50% definitely, 50% Medicaid, Medicare. Primary care, I did note that there's an expanded definition of primary care, including adjunct services like care coordination. In that case, yes, all of them provide those services. If we're talking about primary care in a more narrow sense, no, very few of the behavioral health providers do that.
Thank you. This is Daniel Harper. I will say our provider types included in the rule were the provider types that were explicitly listed in Senate Bill 25290. So we are aligning with the bill, and that's why those types are provided. In our definition of primary care, we do list out comprehensive behavioral health care, since that is one of the provider types that is included in the bill and may not necessarily typically be looked at as primary care. So we wanted to make sure that those services were called out. Now, I think, does that help answer your question and give clarity?
Not particularly. I'm asking about the essential behavioral health providers, the essential safety net providers, and why they're not included. They are essential, after all.
Okay. Thank you. This is Daniel Harper, and I would just say we aligned our provider types with the bill. It isn't within our bounds to expand past what was in the bill, and just making sure that we are aligned with what the legislature passed.
Thank you.
Do I have any other questions from the board?
Madam President, this is Cassie Littler.
Go ahead.
I just wondered, thank you. I wondered who pays for the certification of the patient counts that are verified by an outside entity for the provider stabilization fund? Is that on the provider themselves to have that third party paid for those counts, or is that paid for through the department?
Thank you for that question. This is Daniel Harper. The payment is on the provider, and there are additional options that would not require payment. We have had several providers that have used volunteers in completing the certification and other options that did not impose a cost on the provider.
Thank you.
Do I have any other questions from the board?
This is Amanda, Madam President. We're just trying to review the bill that Mr. Harper referred to review those definitions of essential behavioral health provider and community behavioral health provider. really quickly.
Okay, let's see. Do you guys want to do our first 5-minute recess right now to give you guys the time to review that? Because otherwise I've really got to keep us moving just because our day is so thick.
I think I have an answer. So in this is the 2024 that establishes the safety net provider types. This particular provider stabilization fund excludes the essential bank providers, even though they are a part of the safety net provider apparatus. That's my understanding.
The statute actually excludes it.
That's the provider stabilization fund excludes them. Yeah.
Thank you, Madam President.
You betcha. Any other questions from the board? Hearing none. Okay, Mr. Sykes, I'm going to ask these questions very intentionally. Do we have anyone signed up for public testimony on document 7?
This is Chris Sykes. We do not have anybody signed up to testify on document 7.
Very good. Mr. Sykes, do we have anyone signed up for public testimony on document 2?
This is Chris Sykes. We do not have anybody signed up for testimony on document 2.
Okay, we're going to start with document 7, which is the emergency adoption, again, which puts this in place for a temporary time of 90 days. Do I have somebody wanting to make a motion on document 7?
Madam Chair, this is James McLaughlin. I can take that.
Thank you, sir. I appreciate you.
I move the emergency adoption of document 07-MSB 25-11-28-A, Creation Medical Assistance Act rule concerning the Provider Stabilization Fund Program Section 8.900, incorporating the statement and basis of purposes and specific statutory authority contained in the records.
Thank you, Mr. McLaughlin. May I get a second?
This is David. I second.
Thank you, Mr. Pump. All in favor, please say aye.
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 Opposed?
Nay.
Was that just one, Mr. Sykes?
This is Chris Sykes. Yes.
Thank you very much. Any abstentions? Okay, with that, the emergency rule number 7 passes. Now we are going to do the same thing for document 2. Do I have somebody willing to make a motion for document 2?
Madam Chair, this is Cassie Littler.
Ma'am?
I move the final adoption of document 02 MSB 25-10-13-A, Creation Medical Assistance Act rule concerning the Provider Stabilization Fund Program, section 8.900, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you very much. May I have a second, please?
Barry
This
Martin,
is
I'll
Amanda.
second.
I heard Dr. Martin first on that one. All in favor, please say aye.
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 Opposed?
Nay.
One
One nay.
abstaining.
And one abstaining? That still gives us, that still has that pass. Is that correct, Mr. Sykes? You know math is not my strong suit.
This is Chris Sykes. It does indeed.
Very good. With
Means
that,
it passes.
thank you very much. Document 2 also passes. All righty, now we are going on to both documents 8 and 3. And with that, we have Sarah Caslow with us this morning. Good morning, Sarah.
This is Sarah Caslow. Good morning.
Whenever you're ready.
All right. Good morning, Madam President and members of the Medical Services Board. My name is Sarah Caslow, and I'm the Laboratory Policy Specialist with the department. Today, I'll be presenting MSB 25-08-26A, a revision of the medical assistance rule concerning definitive drug testing. I'll provide a brief overview of why this change is needed, how it aligns with current clinical practice and federal guidance, and the anticipated fiscal and program impact for Health First Colorado. After the overview, I'll be happy to answer any questions. Next slide, please. At the October 10th, 2025 MSB hearing, the department brought forward an emergency rule that set a 16-unit limit per state fiscal year cap on adult definitive drug testing for codes G0480 through G0483. During that discussion, a board member raised an important question: whether a lower limit, specifically 12 units per state fiscal year, might better reflect actual clinical practice. In response to that feedback, we went back and did a focused review. We looked at our current utilization patterns for definitive testing, updated savings estimates, and available national clinical guidance on appropriate testing frequency. Our goal was to directly compare what a 12-unit cap would look like relative to the 16-unit cap in the emergency rule in terms of member impact and program savings, while ensuring we continue to support medically necessary testing. Next slide, please. On this slide, I want to clarify how the 12-test limit works in relation to presumptive testing. First, the 12-unit limit per state fiscal year does not apply to presumptive urine drug tests. CPT codes 80305 through 80307. Those presumptive tests remain fully available and are expected to be the first-line approach for routine urine drug screening and ongoing monitoring. In practice, that means providers should use presumptive testing for most visits and reserve definitive tests for those situations where they truly need more precise information, when there is a discrepancy, a complex clinical question, or when the result will directly change a treatment decision. Because presumptive testing is still available without this 12-test cap and is intended to be used first, we believe that a 12-unit limit per state fiscal year on definitive drug testing is clinically appropriate. It encourages the right sequencing of tests and still fully supports high-quality evidence-based care for our members. Next slide, please. From a clinical standpoint, definitive drug tests are intended for targeted decision-changing questions. For example, when a presumptive test is inconclusive, when there is a discrepancy between reported use and prior results, or when a specific substance needs to be confirmed. They are not meant to be used as routine every visit monitoring tools. National guidance supports this more targeted approach. Both ASAM's guidance on appropriate drug testing and the CDC's 2022 opioid guideline emphasize using toxicology tests when clinically appropriate and avoiding unnecessary or low-value testing. Our proposal is in line with that. We are encouraging appropriate use of definitive testing while avoiding patterns that add cost without improving safety or outcomes. I want to emphasize again that this proposal does not change presumptive testing coverage or unit limits. Presumptive tests remain available for routine monitoring. For members ages 0 to 20, additional definitive testing beyond the limit is still available with the prior authorization. Next slide, please. Based on this analysis, Based on this analysis, the department recommends that the board adopt a 12-unit limit per state fiscal year for definitive drug testing codes G0480 through G0483. Under this recommendation, we would maintain the existing presumptive testing policy and unit limits, and we would maintain the current expectations and medical necessity pathway for children and other, and we believe this approach better reflects clinical best practice, focuses our efforts on reducing excessive and low-value testing, and supports program integrity while still protecting member access to appropriate, medically necessary toxicology services. In short, a 12-unit cap balances member access, clinical guidance, and fiscal stewardship more effectively than the current 16-unit emergency limit. And we are asking for the board's support to move to this limit on a permanent basis. Next slide, please. Thank you. And please let me know if you have any questions.
Thank you, Sarah. First of all, good job, Dr. Costello. It is so inspiring to see somebody who has expertise in the field stepping up with ideas and seeing them get applied. And with that, I'm wondering if you have any questions.
A quick comment.
Please.
Ms. Caslow, thanks for, I read all the testimony, read all your stakeholdering was great to hear from folks. And I just point out for other folks that read that, a lot of people invoked ASAM and CAR requirements, and I agree with your analysis that it did not seem like they understood or willfully disregarded that this only applies to definitive drug testing. I think there are probably financial reasons why they don't use presumptive drug testing, but both CAR and ASAM actually recommend, well, ASAM recommends the lowest intensity.
I'm sorry, Dr. Costello, can you call out your acronyms? Because I don't know what you're talking about and very much want to.
Sorry. ASAM is the American Society of Addiction Medicine. CAR is Colorado Association of Recovery Residences. And both those were invoked by commenters on why they need to use more in definitive drug tests. And I just want to call out that those are not valid. Like ASAM actually says people should use less. CAR recommends that people use some type of testing, but it does not say definitive. So I thought appreciated everyone's comments, but nobody changed my mind on this, that definitive testing should be available but rare.
I appreciate that, Dr. Costello. Sarah, did you have a response to that?
This is Sarah Caslow talking. Thank you very much, Dr. Costello. I appreciate also meeting with you and you giving me some information and background on the differences between definitive drug testing and presumptive drug testing. Thank you. And I agree.
President, this is Kathy Littler. I have two questions.
Okay.
My first question: how will a healthcare organization know in the moment that a patient has reached their 12 limit? And what happens if, since there's no prior authorization process, does the organization that ordered it and, eat the cost of that? Or what happens? How do they know?
This is Sarah Caslow speaking, and I'll try to answer this the best I can right now. There is no way that a provider would know unless they're keeping track of, internally of each member they're testing. The way it's set up now is that once they reach, right now it's at the 16 limit. So once they reach that 16 limit, then the, additional testing would get denied. And that's, kind of then how they would know. Alex or Rachel, do you have any other feedback or answers to that question?
Thank you, Sarah. This is Alex Weichselbaum, Board President. Are you okay if I make further comment?
I've been having some tech problems this morning. I'm actually trying to get my phone to follow stuff too. Yes, please continue on.
All right, thank you so much. So again, my name is Alex Weichselbaum, and I'm the Primary and Ancillary Care Section Manager. On my team is Sarah Caslow, who looks after laboratory services. Presently, and I'm going to echo and support what Sarah said here, providers are only able to keep track of the amount of definitive drug tests that have been billed and paid on their own. Being judicious and clinically appropriate with the tests that they're ordering, the department believes that this is a perfectly reasonable expectation for providers to have. In the future, however, we are examining whether our claim payment system can give providers this information when they query the member's eligibility. This will take a system modification. It could take a few years to build out. So it's something we are thinking about. but is not something we have the ability to do today.
This is Cassie Littler. Thank you for that. I appreciate that. I think, you know, patients don't always get their care in one place. And so I think this is an important piece to build out so that healthcare providers who provide this important service are able to be paid for the work that they're doing and provide the care. So thank you for that.
Did you have a second question?
I did. I wondered if the department could comment on Senator Bridges' stakeholder letter about decreasing the payment for the top two or the highest two G codes, leading to overall savings, but continuing to allow the lower level G codes be paid without a limit.
Madam President, this is Rachel Entrekin, if I may.
Please.
Thank you. Thank you for that question. I will say the department met with Senator Bridges and with one of the stakeholders separately, 2 different meetings, with one of the stakeholder laboratories, Dominion Laboratories. I'm getting their name wrong. Thank you. And we talked through that scenario in both cases. It doesn't actually solve the issue though, because we still have laboratories, providers asking for and laboratories running reflex testing. So every time they're ordering a presumptive test, they're also ordering the higher tier tests. So, we're still open to having those conversations in the future, but for now, it doesn't solve for the problem.
Thank you for that. I appreciate the clarification.
Absolutely.
Those are all my questions, Madam President.
Appreciate you. Any other questions from the board?
Madam Chair, James Remock, just a really quick, I just want to make sure, I believe I read in there that there was an exemption for emergency. Like if somebody presents to an emergency room and they've had, was that correct, or did I misunderstand that?
This is Sarah Castle speaking. In regards to like if a member goes into an emergency room, there's an exemption for that. Is that what you're asking?
Yeah.
No, there's not an exemption for that. Once a member hits that limit, that's just then either the provider isn't gonna get reimbursed for that or the lab.
And I do have some concern about that. If a subacute level provider abuses testing and then that person presents in an acute crisis to an emergency room or an urgent care, and that test is absolutely appropriate, that emergency room or that urgent care where those margins are already extremely tight is going to be penalized for providing the proper level of care. I do have some really big concerns about that. I agree. I think most of the time, absolutely appropriate. This is a big problem. I see people using testing when they should be using screening all the time. Absolutely unacceptable. I think you could potentially be putting lives at risk if you don't exempt emergency rooms and urgent cares from this. And honestly, as I think through it, probably hospitals too, because you're going to need ongoing levels over a prolonged period of time for that patient. If they're admitted to the hospital and say they're undergoing any sort of ongoing acute treatment in an ICU or something like that. So just a thought that I would be concerned. I mean, I know that the emergency rooms that I work with are going to do the right thing, but why should they be penalized for doing the right thing?
Alex, I see your hand is up. Did you wish to respond to this question in particular?
Yes, I would. Thank you,
Please
Madam
go ahead.
President. Okay, so we do have some assurance that this limit is not going to extend to outpatient hospital billing and emergency departments. Those labs are not, the billing for those tests during an emergency are not part of this 16 or soon to be 12 definitive drug testing limit. So they will not be penalized by this.
Does that
Thank you,
answer,
Alex.
that answer your question, Mr. McLaughlin?
It does, Madam Chair. Thank you. I'm much more comfortable with this now.
Excellent. Do I have any other questions from the board? Hearing none. Mr. Sykes, do we have anyone signed up for document 8 testimony today?
This is Chris Sykes. We do. We have Nicholas McDaniel.
Good morning, Nicholas.
Hi,
We will
good
put
morning.
Good morning. We'll put 2 minutes on the clock for you, and the
All
floor
right.
is yours.
Thank you very much. Hi, my name is Nicholas McDaniel. I oversee medical operations and drug testing compliance for a chemical dependency treatment program here in Colorado. First, I need to point out the contradiction in document 8. The emergency revision allows for 16, while the proposed in document 3 limits that down to 12, even though clinical necessity has not changed. Our organization runs several programs of varying lengths, but our most structured and widely used 90-day program means clients will often reach 12 tests before completing treatment altogether. Real-world recovery is rarely linear. Relapse occurs, and people can return to care within the same calendar year. Under a 12-test cap, we don't have the flexibility required to safely monitor members who need continued or repeated care. Among the chief purposes of our program is to stabilize clients, help sustain their sobriety, reintegrate them into society, and ultimately get them off of government assistance completely. We are using definitive drug tests as a tool to help people transition off of Medicaid, which benefits both the member and the state's budget. Artificially restricting our ability to monitor recovery doesn't save money, it prolongs government dependence and destabilizes progress. Limiting tests to 12 undermines the very outcome the state says that it wants and does not reflect the reality of evidence-based treatment. For those reasons, I urge the board to update the permanent rule document 3 to match or preferably exceed the emergency allowance put forth in document 8, because even 16 tests is barely workable, and or create a carve out for structured recovery programs where weekly testing, relapse return scenarios, and confirmation testing are essential for safe treatment. Thank you all for your time.
Thank you, Nicholas. Do I have a response from the department? Am I hearing none? Okay. Do we have any questions from the board for Mr. McDaniels? Hearing none. Thank you very much, sir, for your testimony. We appreciate you.
Thank you.
Do we have anyone else signed up for public testimony on rule number 8 today?
This is Chris Sykes. We do not have anybody signed up for Rule 8.
Very good. Do we have anyone signed up for document 3 for public testimony, Mr. Sykes?
This is Chris Sykes. We have Nicholas McDaniel signed up for document 3.
Good morning again, Nicholas. Were you going to go ahead and give us the same exact comment again?
Yes,
Are you okay with us just saying that that is on record?
absolutely.
I appreciate that. Thank you so much.
Of course. Thank you.
Do I have anyone else signed up for public testimony on document 3?
This is Chris Sykes. We do not have anybody else signed up for testimony on document 3.
Very good. I will start by accepting a motion on document 8, the emergency rule.
I'll make that motion, Madam Chair.
I can't see who that is. I apologize.
Oh, JK.
Hi, JK.
Move the emergency adoption of document 08 MSB 25-11-28-B, revision to the Medical Assistance Act rule concerning definitive drug testing, section 8.660, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you, sir. May I have a second?
Madam Chair, this is James McLaughlin. I can second that.
Thank you very much. All in favor, please say aye.
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 All opposed? Abstentions? Very good. Document 8 passes. I will now entertain a motion for document 3.
Madam Chair, this is James McLaughlin. I'm willing to take that one.
Thank you, sir.
I move the final adoption of document 03 MSB 25-10-13-B revision to the Medical Assistance Act rule concerning definitive drug testing, section 8.660, incorporating the statement and basis and purposes and specific statutory authority contained in the records.
Thank you. May I have a second?
I'll second. This is JP Costello.
Thank you, Dr. Costello. All in favor, please say aye.
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 All opposed? Abstentions? Very good. Document 3 passes. With that, I am putting us in recess for 5 minutes for the long haul. See you in 5. wish I got sung into everything I do. Isn't that great? All right, is everybody back? Mr. Sykes. May I bring the room to order, please? May I bring the room to order, please? Thank you. Team, do you hear me?
Yes.
Excellent. I didn't want to have to do a clap, 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 clap. All right, everybody, onward we go. And we are on to the initial approval portion of the program. We have document 4 with Nicolette Cordova. Good morning.
Good morning. Thank you, Madam President and board members. I believe I have a presentation that they are going to be putting up for me.
Hold on one second, Nicolette. This is Chris Sykes.
No problem. It's Nicolette. Thank you.
Did you send it or was it from Nicolette? I believe I sent it. But, sorry, this is Chris Sykes. Over Kelly. Power of email across the table. Let's see. Both on my end. No. See it.
Thank you so much. So good morning, Madam President and board members. My name is Nicolette Cordova. I work in the Office of Community Living at the Department of Healthcare Policy and Financing. I'm here today to present on document number 4, MSB number 25-07-02-A, the revision to Medical Assistance Act rule concerning, excuse me, the removal of long-term care single entry point in the title. This rule is part of section 8.300 and impacts home and community-based services, or HCBS, case management agencies and members. Next slide, please. The purpose, the rule that is being brought to you today is to address the need to remove outdated terminology from Rule 8.300. Specifically, we're removing the term long-term care single entry point from the title Medical Assistance Section 1, 8.300 Hospital Services Long-Term Care Single Entry Point System. As of July of 2024, Colorado no longer utilizes single entry points. Instead, all such functions are now carried out by case management agencies. The revision came about because the current terminology no longer aligns with Colorado's case management structure, and updating the rule ensures consistency across programs and rule sections. Additionally, there are no longer any home and community-based service case management rules within this section, as those provisions have been moved to Rule 8.7000. Next slide, please. The revision has no fiscal impact and no new funding is required. Revisions to the rule increase clarity and support access to care by ensuring that the program rules accurately reflect the current case management model and are aligned with existing service delivery structures. Stakeholder engagement was completed in July of 2025, and there were no concerns or recommendations made. We also went to public notice in November and did not receive any questions or comments at that time. The last slide will provide a preview of what that rule revision looks like, and I am happy to answer any questions you may have.
Thank you, Nicolette. Do we have any questions from the board? Hearing none. Mr. Sykes, do we have anyone signed up for public testimony on rule number 4?
This is Chris Sykes. We do not have anybody signed up for testimony on Rule 4.
All righty then, I will accept a motion on document 4.
I can take that, Laura.
Thank you, Morgan.
This is Morgan Honey. I move the final adoption of document 4, MSB 25-07-02-A, revision to the Medical Assistance Act rule concerning removal of long-term care single point entry point from section 8.300, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you. May I have a second?
This is James McLaughlin. I'll second for that.
Thank you, Mr. McLaughlin. All in favor, please say aye.
Aye.
Aye. All opposed? Abstentions? Wonderful. Document 4 passes initial approval. On to document 5 with our friend Rachel Larson. Good morning, Rachel.
Good morning, everybody. Good morning. Give me 1 second, please.
You got it.
All right. Good morning, Madam President and board members. My name is Rachel Larson, and I am a compliance and policy advisor for the department. I'm here to present MSB 25-8-12-B, revision to the medical assistance rule concerning vision services updates, section 8.203. I'm joined today by Christina Winship, State Plan Child Health Policy Specialist, and Kelsey Leva, Policy Development Stakeholder Engagement Specialist, and they will both be available after this presentation to assist in answering any questions today. Excuse me. As you may recall, the department brought a rule proposal to this board regarding vision services updates, which was adopted at final adoption in July of 2025. That was MSB 25-5-20-A, revision to the Medical Assistance Act rule concerning vision services changes and early and periodic screening, diagnostic, and treatment, EPSDT alignment, section 8.203 and 8.280. Prior to the final adoption of that rule, the rule had in it some changes related to providers eligible to order, prescribe, refer, or render vision services. However, at that time, there was a pending state plan amendment that we were working on with the Centers for Medicare and Medicaid Services, or CMS. Because the department was still working on the state plan amendment language when the final adoption took place on that rule package, the department then removed any changes to the rule related to that issue. The relevant state plan amendment was approved by CMS on July 30th, 2025. Therefore, the department brings this rule before the board today to align the rule with the language in that state plan amendment. The rule proposal before the board today makes a few changes to rule section 8.203. The first is technical changes, such as adding lettering to the definition section, making spelling fixes, and adding the medical necessity definition reference from the EPSDT rule. The second is amending the providers eligible to order, prescribe, refer, or render vision services to include those providing services within their scope of practice per state law. Specifically, the rule lists optometrists, ophthalmologists, and other physicians acting within the scope of their licensure. Also, it adds advanced practice nurses, physician assistants, and registered nurses. Finally, the rule adds language regarding clarification in using the National Provider Identifier for billing. Overall, this rule proposal will ensure providers, members, and stakeholders will have more clarity and options regarding approved providers offering vision services. Now, the department did conduct a stakeholder engagement process to gather input from providers, and that included one public stakeholder meeting on July 17th, 2025, as well as a public opportunity to submit feedback electronically. Stakeholder questions were answered live during the meeting, and adjustments to the proposed policy were made based on the feedback received from providers to be as inclusive as possible. All feedback and department responses are documented in the stakeholder log for your reference. Board members can access the stakeholder log and summary on the member website under the rules. Thank you for your time this morning, and we are open to any questions that you may have.
Thank you, Rachel. Do I have any questions from the board? Hearing none.
This is Jamie.
Go ahead, Dr. Costello. I hear you.
Yeah, question for Ms. Larson. I know that one of the benefits of this is an expansion of availability of vision services, but it also says that there will be no change in, there will be no cost to the department. Can you reconcile those two statements?
Ms. Winship, I don't know if you'd like to handle this question. She's more familiar with, she's in charge of the vision policy.
Sure. This is Christina Winship, Madam President and members of the board. I manage the vision benefit. So all of these benefits are already available to all of our members. We're just broadening the category of providers that are officially included under all of our regulations. It's entirely possible that these services were already being provided and reimbursed, but just weren't formally included under our regulations. We also reimburse these services at the same rate regardless of who delivers them. So we want to ensure that members, if they're able to see a local provider for this, that they can get reimbursed instead of having to travel, things like that. And also, this is part of our responsibility as a Medicaid agency, right? To include any willing provider who is delivering a service under the scope of their licensure.
Did that work for you, Dr. Costello?
A bit. I'm all for this, but I'd like to see it reflected in the anticipated costs, that greater accessibility, more local accessibility, more providers providing services will probably result in more vision services being provided.
Christina, did you want to answer that also?
Sure, this is Christina Winship. I think it's just more likely that our regulations will reflect the reality of services already being delivered.
Dr. Costello?
Thank you.
Wonderful. Any other questions from the board? Hearing none. Mr. Sykes, do we have anyone signed up for public testimony on document 5?
This is Chris Sykes. We do not have anybody signed up for testimony on document 5.
Very good. I'm going to pop in with a point of order here real quick. My colleague, Mr. Honey, noticed that in our pre-written motions that this one is called final adoption instead of initial adoption. So whomever it is that takes this motion, if you could please say initial adoption instead of final adoption when you take this motion, that will make us legit.
I'll take that, Laura, and I'll ask whomever in the room, do I need to amend the previous adoption to note initial adoption, or can we just note that in the record?
Rachel, what do you think about that?
Thanks, Madam President. Rachel Intrican. I do think we probably need to amend it for the record, to be clear.
All right,
Laura,
so
then
I'm going to do a document 4 and then a document 5 so that we have a clean 4. Is that what we're thinking, team?
Yeah, and I can take both of those, Laura, just to keep it streamlined.
I appreciate you so much, Morgan. Thank you.
Okay.
Let's do document 4.
All right, I amend the previous, well, let's see. I guess I withdraw the previous, or I amend the previous motion on document 4 and would move the initial adoption of document 4, MSB 25-07-02-A, revision to the Medical Assistance Act rule concerning removal of long-term care single entry point from section 8.300, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you. May I have a second?
This is James McLaughlin. I'll second.
Thank you, Mr. McLaughlin. All in favor, please say aye.
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 All opposed? Abstentions? Floor is yours to do document 5 motion, Morgan.
All right, this is Morgan Honey. I move the initial adoption of document 05, MSB 25-08-12-B, revision to the medical assistance rule concerning vision services updates, section 8.203, incorporating the statement of basis and purpose and specific statutory authority contained in the records.
Thank you. May I have a second?
This is David, I second.
Thank you, David. All in favor, say aye.
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 All opposed? Abstentions? Very good. We have gotten through initial approval. Again, Mr. Honey, thank you for catching that and helping us make it right. We are a team and I appreciate y'all so much. All right, team. We are on to document 9. Good morning, Rachel. Let's see, I have Rachel and I have Kelsey. Anybody else part of your team going to present this morning, Rachel, so I can call them out for record?
Rachel Entrikin will also be a part of our presentation today.
Duly noted. All righty, team. We are off and running with document 9.
All right. Good morning, Madam President and board members. My name is Rachel Larson, and I'm a compliance and policy advisor for the department. I'm joined today by Kelsey Leva, Policy Development Stakeholder Engagement Specialist, and Rachel Entrikin, Legal Division Director. We are here to present MSB 25-9-4-A, creation of the Medical Assistance Rule concerning Pediatric Behavioral Therapy, or PBT, as an emergency rule. We are also joined by various individuals from the department who will be available for questions after this presentation. Next slide, please. As an overview, the department is asking this board to approve the creation of a section of regulation, section 8.281, regarding pediatric behavioral therapy. I will be referring to that today as PBT. The department's goals for the creation of section 8.281 are to ensure continued access to safe, high-quality services for children who are enrolled in Health First Colorado, and to avoid unintended consequences that put this critical resource at risk. We know that rates have been a hot topic with this provider group. We just want to let you know that rates are not a part of the rule proposal. They are instead addressed in the Medicaid Provider Rate Review Advisory Committee, which is also known as MPRAC. Just to let you know where we are headed here, I will explain a little bit about the history of PBT, then I will move to the reasons the department is bringing this rule as an emergency today. Next, I will explain some of the fiscal challenges involved, and finally, I will give an overview of the topic areas within the rule. Kelsey will also be highlighting the stakeholder process for the board, and Rachel Entrikin will close out our presentation. Next slide, please. Historically, PBT has been covered as a part of EPSDT, which stands for Early and Periodic Screening, Diagnostic, and Treatment. EPSDT is an expanded package of Medicaid services for children and youth ages 20 and under. Now, in 2012, the Children with Autism Waiver in Colorado was established by Senate Bill 12-159, offering applied behavior analysis, or ABA, to a small group of just 75 members who qualified for the waiver at that time. Then, in September of 2015, the Federal Centers for Medicare and Medicaid Services, or CMS, denied the Colorado Children with Autism waiver, indicating that those services should be covered in the EPSDT program. In April 2016, just 7 short months later, the PBT benefit began its operation. The rule proposal before this board today is driven by initial findings the department received after the Federal Office of Inspector General, also known as OIG, conducted an audit on the Health First Colorado PBT benefit. In September of 2025, the department identified the need to build out a rule section specific to PBT, instead of having it live under the general rule section of EPSDT with no specifics outlined. Now, to clarify, with the move of PBT to its own rule section, the EPSDT program will still apply, as it does to all benefits and services for those ages 20 and under. We did some initial stakeholdering and planned to bring this rule before the board back in October. However, based upon stakeholder feedback, we decided instead to bring the rule in December so that we could conduct additional stakeholdering and rule revisions. Next slide, please. Let's go into more detail about these audit findings. The OIG has instructed the department to not share details about the draft findings in the report, but what the department can share is themes and impressions. Here's what we learned and what inspired us to take immediate action. Tens of millions of dollars in payments were made to providers for services provided by uncredentialed PBT technicians. Currently, credentialing for these technicians is not clearly required in our regulations. Service documentation and billing practices were also improper. The department is really between a rock and a hard place here. The OIG findings are confidential, and we have been directed by OIG that we cannot share the draft findings. What we can share is that there are over $100 million in findings, and about 1/3 of them relate to technician credentialing. The reality is, any loss in funds for this benefit will impact the health, safety, and welfare of all Health First Colorado members. We expect the OIG will tell Colorado to pay back over $60 million due to these audit findings. Next slide, please. Next, I will outline our reasons for bringing these changes forward as an emergency rule. First, we are addressing urgent compliance issues outlined by the audit that I just mentioned. The rule proposal will increase clarity for providers by formalizing critical expectations in a dedicated PBT rule. The rule proposal also ensures continued access to safe, high-quality services for children enrolled in Health First Colorado. Given the state is in a difficult budget situation, this rule proposal seeks to minimize the risk of losing matching funds from CMS by ensuring that every dollar we spend is defensible to protect all Medicaid benefit areas, including PBT. Finally, there's a pending lawsuit challenging the department's policy memo 25-5 dated July 18th, 2025, and the provider bulletin dated September 1st, 2025 about PBT requirements on the basis that they violate the Colorado Administrative Procedure Act since there was no rulemaking. Now, though we disagree with the allegations in the complaint, we do agree that rulemaking is important. While the emergency basis for the rule came from a specific training and supervision problem for which rulemaking was identified as a solution, the department cannot create one section of rule to address the issue in a vacuum when no PBT section of rule previously existed. Regular rulemaking processes can take as long as 6 to 8 months to complete. The pressures I have identified do not allow for that slower process. Although we do not believe it is relevant to this rulemaking, you might also be familiar with another lawsuit that challenges the PBT rate reductions necessitated by the current budget crisis. To tie this all together, we can best protect federal funding and this important benefit by moving quickly to address these compliance issues. Next slide, please. Let's dive a bit deeper into the budget situation. The cost of the PBT benefit for fiscal year 22-23 was approximately $157 million. The total cost of the PBT benefit for fiscal year 23-24 was approximately $207 million. The total cost of the PBT benefit for fiscal year 24-25 was approximately $287 million. The cost of the PBT benefit is growing significantly year over year and grew approximately 45% from fiscal year 2022-23 to fiscal year 24-25. That trajectory is not sustainable for the state and ultimately puts this benefit and others at risk. Now, there are many possible reasons for this unsustainable increase in spending, including increased provider rates, some providers' behavior, requiring minimum patient hours per week, billing for services provided by uncredentialed technicians, and billing for non-therapeutic and non-contact hours such as naps and playtime. As everyone is already aware, Colorado Medicaid has limited funds, and we are experiencing a severe state budget crisis. Without this emergency rule, Colorado not only risks having to pay back additional funds to CMS, but also risks losing federal matching funds, which cover approximately half of all PBT service costs. Any loss in funds will impact the availability of these services and the health, safety, and welfare of all Health First Colorado members. At this time, I would like to hand it over to Kelsey to highlight the stakeholder process on this rule. Thank you.
Next slide, please. Thanks, Rachel. Good morning, Madam President and members of the board. I'm Kelsey Leva, and I'm here with you today to speak to stakeholder engagement on the proposed rule. The department held 2 general stakeholder meetings, met with existing advisory groups, and offered an ongoing public option to submit feedback electronically to inform the proposed rule. As you have heard, we initially planned to bring the rule to you in October, but delayed our presentation at the final hour to allow more time to fully address questions and feedback. After a thorough revision of the rule, we held a follow-up stakeholder meeting on November 19th to present the updated rule and respond to questions and feedback. The rule that you see before you today incorporates many changes informed by stakeholder feedback, including a narrowing of the focus so that the rule addresses only the urgent issues, clarification and expansion of the allowable types of behavior technicians, and clarification regarding supervision requirements for behavior technicians. Questions submitted by stakeholders were responded to live during the meetings and by publishing a question and answer document. All feedback and department responses are documented in the stakeholder log for your reference. Board members can access the stakeholder login summary in the member website under the rule. This proposed rule is only the beginning of a multi-step policy development process that we plan to continue on with stakeholders through additional stakeholder engagement and non-emergency rulemaking. I'll hand it back to Rachel now so she can go over the rule in a little more detail for you.
Thank you, Kelsey. Next slide, please. Just to go over a little bit of what the proposed rule section 8.281 contains. The rule section outlines standard topic areas that you would see in other department rules covering other benefit areas. Those topic areas include purpose, definitions, member eligibility, provider requirements, benefit limitations, prior authorization requirements, and non-covered services. One area that is gaining a lot of attention during this rule revision is the part about supervision and certification requirements for behavior technicians. It is important to note that in the area of commercial health insurance carriers, there is a state statute, CRS 10-16-104, that requires behavior technicians to be nationally registered by a certification body. There are a couple of areas such as covered services and reimbursement that we are reserving for future rule development. We left out those areas for now so that we could focus on areas of the rule that were an emergency. We do plan to build out those areas down the road with future rule development and further stakeholder engagement. Next slide, please. Now, I would like to draw the board's attention to a last-minute edit the department did make to the rule yesterday. The revision was based upon stakeholder feedback and clarifies section 8.281.2.b.1.b. And it reads, an active license by the Colorado Medical or State Licensing Board, if applicable. This change was made to clarify where board-certified behavioral analyst doctoral level fits into this regulation. At this time, I would like to hand it over to Rachel Entrekin, who will close out our presentation. Thank you.
Good morning, Madam President, if I may. Thanks. I'm Rachel Entrekin. I'm the Legal Division Director for Healthcare Policy and Financing. And I have just a few more pieces of information for the board. Before I dive in, though, I do want to just thank everyone who's here today. We can see the passion in the room, and we can see how important this issue is to you. I really want to make it clear that we have listened to stakeholders very, very closely throughout this process. So I appreciate you being here today. Before we close out, I want to address a topic that we received a lot of stakeholder feedback about, and that you have probably seen a lot of stakeholder letters about already in the record. This is the request for a paid training period for uncredentialed behavior technicians, which you may stakeholders refer to today, or you may have seen in the letters, calling that a grace period. So this topic came up during both stages of stakeholder engagement. After the first stakeholder meeting, we contacted the Centers for Medicare and Medicaid Services directly, that's CMS, in writing to determine whether paying for uncredentialed technician services was permissible. Because at the same time we were getting this request and this feedback from the community, we also had the OIG findings that Rachel Larson talked about earlier, where about a third of those findings are based on services provided by uncredentialed technicians and then billed by billing providers. So we're getting two very different sets of feedback. The issue that we're seeing, of course, is that if OIG maintains this finding in a final audit report, which we don't have yet, once we have a final audit report, we can share that publicly. There have been some questions about why we haven't shared that audit, and that is because the findings are confidential until OIG makes their report final. So if OIG maintains their stance in the final audit report, Colorado will be required to repay the federal match identified in the report, which essentially means that all of those services that were billed and paid for are paid only with state general fund. As you know, we're right in the middle of a state budget crisis. We had to cut $1 billion from the state budget earlier this year. And then with the passage of the federal HR 1 bill, we had to cut another $1 billion from the state budget. And that's billion with a B. Without CMS permission, express permission to use federal funds in this manner, the department faces a significant risk of also having to pay back current and future federal funds that we may have drawn down for a match to pay for uncredentialed technician time. Next slide, please. Sorry, next slide there. Thank you. So I just wanted to share with folks some information. I know this is really small, sorry about that. Some information from the Council of Autism Service Providers, CASP. They're one of the national autism service provider associations. They did some research earlier this year to find out what states cover uncredentialed technician hours and what states don't. So I don't know if you can read this from here, but on the left, it says states that allow a grace period for technicians to obtain credentials. There are 7 states listed there. 6 states listed there. The first state, Illinois, I guess, is going through a state plan amendment process with CMS to get permission to pay uncredentialed technicians. All of the other states on the right are states that require a technician to obtain their credentials prior to rendering care to Medicaid beneficiaries. And so it is pretty uncommon for states to cover uncredentialed technician time. And I just want to be really transparent and clear. Until we received the audit findings from OIG, it was not apparent to us how many uncredentialed technicians were providing services in Colorado. I just want to make really clear, we've compromised where we can on this rule. We're doing our very best to both try and look at future policy choices that meets the needs of our members and our stakeholders, while at the same time being very, very careful that we are not paying for uncredentialed technician time at a time that we've been told that we can't draw down a federal match for it. That at a time when we are in a very deep budget crisis, this is, I know that this is not the answer that many stakeholders have been advocating for, and all the folks in the room tell us how much passion there is around this. The door is not closed to this topic, but at this point now, we cannot say yes. We do not have good legal grounds, and we certainly don't have good budget grounds. We need to make sure that we are protecting these dollars, not just for the folks who are receiving uncredentialed technician hours, but for the 1.2 million people who rely on Medicaid for everything that they get through healthcare. And we will certainly continue to evaluate this request and involve stakeholders in future policy developments. So this concludes our presentation. Thank you so much for your time and attention. Please let us know what questions you have.
Thank you, team. Do I have any questions from the board?
Laura, this is Morgan.
Please, Morgan.
So, Rachel, obviously, I believe everybody on the board has spent a lot of time reviewing the stakeholder feedback and the ins and outs of this. Just a couple points of clarification, if you wouldn't mind. So pulling from all of the different information and not rehashing what you just said, somewhere I picked up that we have about 6,000 of these technicians, and I think that you just said that we're not quite sure how many of those 6,000 are uncredentialed versus credentialed. So if you could make sure that I'm correct about that statement. And then subsequently, if we don't know what the delta is in terms of how many people need to be credentialed, then what is, then my question would be, do we have the capacity in the state for credentialing that volume of individuals that are out there serving recipients now? Or, the 60 to 90 days that I continually read throughout the different documents, is that going to be pushed even longer because we're going to have this huge influx of these technicians, scurrying to get certified, and thus, could go 6, 9, 12 months before, the credentialing capacity can keep up with how many of these folks are going to be going through the system. And then secondly, I would ask on the stakeholder feedback, how do our stakeholders know whether they are definitively going to be impacted by this? Are they aware that they're receiving services from an uncertified technician? Is there the potential that that some of the stakeholder feedback that we got is not necessarily going to be impacted because I may or may not know that my technician is credentialed? And then lastly, I would say, if all of a sudden, and again, reflecting the stakeholder feedback, if we approve this today and it goes into effect and, tomorrow there is, let's say, half the number of technicians available and those services, come to an abrupt stop, what are the other alternatives for services and, for these kids that are available? And quite frankly, I think about, if I'm receiving probably a more efficient level of care in terms of cost by having a technician provide these services, where are we anticipating that these folks are going to go elsewhere in the system? And, are we risking, and I understand all of the OIG audits and have worked with CMS for a long time, so I get that part. But, the alternative is, are they going to be hitting inpatient facilities? Potentially, are they going to, what other access to services are going to offset the reduction in services here? And even though those other services may meet CMS compliance, I would have to assume that they're going to come at a higher cost. So hopefully you got all that, but happy to back up if you need me to.
Yeah. Thank you, Mr. Honey. Rachel Intrican for the department. Following up, I think from the beginning of your questions, I think your first question was, do we have an understanding for how many behavioral technicians are currently credentialed? The Council of Autism Service Providers, or CASP, tells us that currently there are about 75% of technicians who are credentialed. We have been talking about this credentialing requirement since July. Credentialing usually consists of 3 pieces, as I understand it. There is a 40-hour course, followed by a test in person, a written test, and there are also practical hours on the job training that technicians receive. Honestly, I think one of our hopes is that we have a lot of people who are on the verge of being credentialed, because if people started the process, they are either already credentialed or close to it. But I think that answers part of your question and also raises the question what you're talking about for individuals who may be getting services from uncredentialed technicians. I don't know what kind, and it's a little opaque to the department, what kind of disclosure families get in terms of whether or not the technician that's working with them is credentialed or uncredentialed. And so I don't know how families would know if they particularly would be impacted or not. We have certainly seen a lot of communications from some of the larger PBT providers in the state talking about immediate impacts. We are certainly hoping that the providers, as our partners and as the important link between our programs and our members, that they are taking the credentialing process as quickly as they can to make sure that there is as little barrier as possible. Oh, sorry, one last comment. I did want to say, we do have, I think it's been about 5 months since we started, 6 months since we started talking about credentialing. So I am, like I said, I'm very hopeful that we have technicians who are in the credentialing process now.
Thanks, Rachel. So before I get to the last question, so let me repeat back to you just for clarification. So we estimate that 75% of the 6,000 number that I have somewhere in my head is currently certified or thereabouts. So at least about 1,500 of these technicians that need to be certified. These conversations started mid-summer, and the requirements are approximately 1 week, 40 hours of training, oversight, a written certification exam, and then I think you said 15 hours. So, not a long time to get that certification if we're talking about it's already been 5 or 6 months since we started this conversation. And then secondly, your statement that it's hard to quantify how many of these families might be impacted because whether or not their technician is certified may or may not be disclosed at the time of service. Did I get all that right?
Yes, although I did want to correct, out of the RBTs in the state, we do know that I believe from COABA, which is one of the state trade associations, that as of July 14th, there were 5,463 certified RBTs in Colorado. And as of this week, there are 6,641 certified RBTs. So we definitely have seen some movement.
Okay. So then I'm not quite sure where I got that. This is Morgan Honey. I apologize, Laura. So I'm not quite sure where I got that 6,000 number. I pulled it from one of the documents. So sounds like the 6,000 that I was using as the denominator for technicians in the state is wrong because you've already got more certified. So would be curious how many of those technicians, remain uncertified at some point. Again, trying to get to the stakeholder feedback. Hard to know whether or not I'm impacted because I may or may not know whether my technician is certified. And then my last question, Rachel, would be, what are the alternatives for these folks in terms of other services available if I am indeed, coming to an abrupt halt because my technician is not certified? Or is there a scenario where perhaps while my technician is getting certified, there is an alternative technician that could come and augment the services that I'm receiving while while my particular technician gets back into the requirements.
Yeah, absolutely. Great question. Madam President, I'd like to pass the mic. This is Rachel Entrican. I'd like to pass the mic over to Gina Robinson, our policy specialist.
Hi, Gina. Good morning.
Madam President, and thank you. My name is Gina Robinson. I'm a senior policy advisor within the Health Programs Office. So, great question. We don't know how many of those non-certified providers in the state are working with Medicaid eligibles at this point in time. Unfortunately, we have no transparency into how many that may be. I do know that those providers who may operate in the states that you see listed for not allowing credentialed providers would have a process and a ability to move providers around in order to better serve Medicaid clients and those that may be seeing them with some type of private insurance, or even our members who have private insurance and Medicaid secondary.
Thanks, Gina. Laura, just one. This is Morgan Honey. One more. So I'm trying to pin you down, guys. So if I'm in a scenario where my technician says I can't show up tomorrow, what do I do for services tomorrow? If I'm one of these folks who submitted stakeholder feedback.
Thanks for that question, Madam President. Morgan, we would actually have been trying to obtain that information from some of these providers about what our options are. Could that be, right, like you said, moving providers around, sending a different technician who is certified over one who is not until that non-certified technician is certified, and then switch them? I know that it's not the best scenario, but it is an option.
Does that do it for you, Morgan?
Kind of. I guess I will just state my claim and then I will shut up and you can move on, Laura. So this is Morgan Honey, and I think and disclosure, I am an accountant by training, so I always appreciate numbers, but I spent my entire career in healthcare and understand how numbers are not always linear in healthcare, if you would. So I would just say that there are some expenditures in the Medicaid budget that we want to see increase over time because it is a more efficient and effective way of taking care of the population so that they aren't ending up in higher cost of care settings. So, I always take the presentation where it says we have grown these expenditures by 45% year over year, as that may not necessarily be a bad thing if it means that these individuals aren't ending up in a different set of care where we would see 75 or 125% of those expenditures increase year over year just because of the cost of where they're accessed. So I would just, from my perspective to the department, when you say increase in cost, well, that's not always a bad thing if you back up and look at the totality of where expenditures are being made. That's just to say, I completely also understand the OIG report, the need to be in compliance. It sounds like you addressed my concern that, repayment of the OIG audit is a foregone conclusion. It sounds like that may or may not be the case. But I do certainly understand, the need to get into compliance with CMS to make sure that the totality of the Medicaid budget is safeguarded. It sounds to me like, there is a portion of this provider population that will need to go through the certification process. For me personally, someone who has worked in the healthcare system and employed individuals that require certification and the like, if I had known about this starting in July, I would have done everything I could to make sure that that portion of my staff was on a path to meet the potential requirement in the future. And it sounds to me like these requirements are not overwhelmingly are not overwhelming. I'll just leave it at that. And so, from my perspective, I understand and have read all of the stakeholder comments. Definitely, have lots of folks in my personal life that are impacted by autism and other conditions that require lots and lots of services and support. But there is also, the requirement for us as a board to support the department and make sure that we are maintaining compliance with CMS and looking at the entirety of the Medicaid budget and how we're ensuring that we're safeguarding those assets. And so I will just leave it at that until we get to the time of the vote.
Thank you, Morgan. Did we have a response from the department?
Yes, Madam President, this is Rachel Entrican. Mr. Honey, I really appreciate your comments, and I also really appreciate your insights as both an accountant and someone who's worked in healthcare for a long time. I guess I would have a couple of responses. First, I think you raised the question of, sometimes we see trends, an uptake in services that are a really good thing, and you're absolutely right. And that is true here too, right? I don't want to give the impression that all of this growth is untoward or in some way unwelcome, because that's not true. But what I do want to say is we've seen a plateauing of participants and no plateau in cost, which is always concerning to us in the Medicaid department. If we're looking at a population of patients that's not growing, but costs that are growing at significantly higher rates, that is something that we have to be aware of. I think the other thing that I didn't address in my earlier comments that I really want to address here, and that is quality of care. The people who we're talking about, who receive these services, these very important services, are some of our most vulnerable members. They are children with autism. They kind of across the spectrum, right? But we have to make sure that the people who are working with them in a clinical setting are really qualified to do that. And allowing uncredentialed technicians to continue to provide services without having any insight into what the quality of care is also not a great option. Certainly I do want to let this group know that the OIG report in support of their finding also has raised a quality of care concern, and that is not something that we take lightly. Because the credentialing process is, to Mr. Honey's point, not insurmountable, it is pretty reasonable. We have been assured by many of the stakeholders who have commented that their technicians are very well trained. We want to make sure that there is a standard that everyone has to meet to ensure that the care that the people are getting, whose care we are paying for, is quality care and does not raise quality or safety concerns. So I did not bring that up at the beginning, and I should have, because that is certainly something that is also driving this decision.
Thank you, Rachel. This is Laura Carroll. I just had a really quick follow-up to one of the questions that Morgan asked before we go on down the line. You had indicated that conversations about this started this summer, and I'm just wondering how those conversations started. Like, how were people notified that there was a problem here?
Yes, thank you, Madam President. Rachel Entrican here, and I am once again going to pass the mic to Gina Robinson and Kelsey Leva.
Thank you, Madam Chair and Rachel. This is Gina Robinson. We did reach out to several providers who may have been are part of that audit, and learned from them what they were told from OIG and started the conversations at that point in time. We also noticed through a memo, as well as provider bulletins and the stakeholder meetings that Kelsey mentioned. Kelsey, do you have anything to add?
I do not, thank you.
Thank you. So Laura Carroll again. So at some point, all of our providers who provide this service have been notified that this is going on. Am I correct? And that happened as early as the beginning of this summer. Is that also correct?
Chair, this is Janie Robinson. That is correct.
Wonderful. Thank you for the point of clarification. Do I have any other questions from the board?
President, this is Cassie Littler. I'm not sure who to direct this question to, maybe Gina. But I wonder, to Morgan's point, if patients have an unregistered clinician and they lose their services on Monday, what is the responsibility of the department through EPSDT standards to provide reasonable promptness to care? Like, what does that look like?
This is Gina Robinson again. We unfortunately under EPSDT don't have the ability to make business changes. What we can do is offer other services, offer providers who may not have wait lists, and we do ask those providers who don't have wait lists to reach out to us so we can help fill them up. So that would be what we could offer as far as immediate options for services in the community as well.
That answers the question.
I think this is Cassie Liller. I think it answers the question, but it doesn't give necessarily logistics of how that looks on Monday. So just thinking about the most vulnerable children in our community and the services that they need. But I understand that this is really complicated and we're sort of stuck. But I just, worry about our most vulnerable children. Thanks for that. I do have a second question. And I wondered how this works. It's the pre-licensure or unlicensed providers in the behavioral health realm. They have a mechanism to be able to bill under a rendering provider. And so I wondered how this is different, and is it because these services are not included in an 1115 waiver? How is that different from behavioral health pre-licensure and unlicensed providers being able to bill as a under a rendering provider?
Yes. Madam President, this is Rachel Intrican. Thanks for that question, Dr. Littler. My understanding is that, so registered behavior technicians, in terms of like baseline criteria, they have to have a high school diploma and be over the age of 18. And so requiring additional credentialing in the department's view is very appropriate, because we're not talking about an unlicensed provider who may have finished a college degree and a master's degree before they sit for their boards. And have a lot of training under their belt. So this sort of baseline credentialing will ensure that they have some training, some classroom time.
Thank you.
Thank you.
Madam President, this is Dr. Manishalski. May I ask a question?
I'm sorry. I hear that you have a question, but Dr. Martin has been waiting very patiently with his hand up, so I'm going to give him the opportunity to speak, and then we will come right back to you. Dr. Martin, go ahead.
Thanks so much. This is Barry Martin. It seems like, reading through all of the community testimony, that no one says that people shouldn't be qualified, but the issue is how quickly they can get everyone qualified and about the grace period. So I have, I think, a three-part question about the grace period. One is, you probably said this and I missed it during your presentation, but for the 6 states that have a grace period, why can't we be the 7th?
Dr. Martin, thank you for that question. This is
Is something going on?
There was a lot of applauding from our stakeholders who are in the room.
Splendid. I wish I could hear that better.
Yes, Dr. Martin, Rachel Entrican, for the department. We have two major roadblocks right now with becoming the 7th state. The first roadblock is the fact that we have an OIG report that tells us that we can't draw down federal funds to pay for uncredentialed technician time, which would mean that those funds would only come from general fund only, which is, we typically don't have the ability to pay state fund only unless the General Assembly has told us we can. The other issue being that will have financial impacts on all of our programs, including PBT. And so we are trying to find a middle ground that satisfies a policy need, that quality of care side, that satisfies the fiscal bind we're in with making sure that RBT's time can actually be billed for, right? Behavioral technicians are not billing providers, but their time can be billed by billing providers. And that is what we see in terms of the work that registered behavior technicians do will continue to be paid without any change. It is for those non-credentialed behavior technicians that we are asking that they become credentialed as quickly as possible. This is the same message that we've been sharing since the summer to ensure that we have that quality of care and that federal match. And we don't have a guarantee that we will have any federal match at this point. And in fact, we have the U.S. Department of Health and Human Services Office of Inspector General telling us we can't draw down a federal match. So that's the barrier.
So follow-up question, if I can, Laura.
Please.
Again, this is Barry Martin. So the 6 states that do have a grace period, your understanding would be that they're all paying for that out of general funds?
My understanding is that some of them do not only pay it out of general fund, Dr. Martin. I know that there are states that have either an approved state plan amendment. There's one at the very top of this list that's really hard for everybody to read. Illinois has a pending state plan amendment. And I don't know, honestly, how the others are paying for it now.
And I did notice in one of the outside comments that we got, they said that Wisconsin, I think, has a grace period and the OIG didn't say anything about it apparently. And I noticed that Wisconsin is not on either list. I don't know if you have anyone has any thoughts about where Wisconsin is. Apparently the OIG did not tell them that they needed to do this emergently.
That's my understanding. Sorry, Rachel Entrican for the department. That's my understanding as well, Dr. Martin. The Wisconsin report is public. Colorado's report is not. What I can tell you is that Colorado's report and Wisconsin's report are not identical.
Okay. So I guess two other questions, if I could. Again, this is Barry Martin, or
go ahead.
And I'll state them both up front. I'm hoping they're not too difficult. One would be, can we advocate for CMS to grant a grace period and or do a state plan amendment so that we can have a grace period? And then my second part of that question would be, lots of people have said, we have a 90 or 120 day grace period. I'm wondering, could we have a 30 or a 60 day grace period? Is any grace period possible without families going without services for some amount of time?
Yeah, Dr. Martin, Rachel Entrican again. You raise an important point, and it's certainly one that we wish we had an answer to today. We have not heard back. We got some clarifying questions from CMS, but no response at this point. That said, it is certainly something that we intend to continue to pursue answers to. I think the challenge is how quickly that can happen versus how much of a federal match we still are currently drawing down for these non-credentialed behavioral therapy services. One of the things that we have talked about internally, we have given a number of extensions to what has already been a pretty robust grace period here of the 6 months or so that we've been talking about this in the provider community. One of the things that we have talked about is the possibility of making one last extension in our emergency rule today, asking for an effective date of February 1st instead of December 12th. To really allow folks who are on that path and going through the necessary procedures to become credentialed so that we can strike that balance between access and making sure that we are serving all of our members in a way that makes sense fiscally.
So just real quickly, just make sure I understand this, Barry Martin again. So if we pass this today, it would not be implemented until February. And so we would have, depending on when in February, I guess, at least a 30, possibly 60-day grace period in addition to what people have already known about.
Yeah, Dr. Martin, Rachel Entrekin, just to clarify, in our current rule, we have been asking for a December 12th start date. We share your concerns about access. We share the stakeholders' concerns about access, which is why I'm raising the possibility of the department amending the emergency rule today to ask for a February 1st start date instead of a December 12th start date.
Thank you so much.
Thank you.
I know I had other questions in the room.
Yeah, sorry. This is Dr. Manischewski. I had a question. I was wondering if folks from the department can reflect on whether they saw, since this conversation began in July, a large uptick in people who sought credentialing, whether there was a response from providers in the community or the organizations that you worked with, the stakeholders that you spoke with as they became aware of this potentially upcoming rule change.
Madam President, Rachel Entrekin again. I will make one comment and then pass it back to Gina Robinson and Rachel Larson for additional comment. I think the answer is yes, and, or yes, but. I think that a lot of people have made the move towards credentialing. Certainly in the numbers that I read off a little bit earlier, the difference between July and now is about 1,200 people, which is a great improvement, but it's still nowhere close to 100%, which is where we would like to be. That said, we are certainly balancing a tough choice here in terms of how we protect the funding for these services and other services, protect quality of care, and make sure that our members are getting access. So let me stop there for a moment, if I may, Madam President, and see if Gina or Rachel have comments.
Sure. Thank you, Rachel. This is Gina Robinson. I did have providers who reached out to say that they already only had credentialed staff and this did not actually affect their process or their services. I have had other providers who have reached out and said that they would have no problems meeting either of the two previous deadlines. And so I think it's mixed on the response that we've been getting from providers, whether it can be met or not.
Thank you.
I see your hand up. If you want to carry, you can keep on going as long as you've got the floor. It is so hard for me to see hands like that, though. So thank you for that.
Madam President, this is Kathy Littler. It's not Amanda. It's Kathy Littler.
It is so hard to see you guys. Thank you for grace.
Yeah. I had a question. If you guys look at the rule 8.281.1.b. And I just wanted to know some clarification because I feel like these services are really confusing to me as to where they're paid from. And so this says that PBT services are delivered outside of the Health First Colorado behavioral health benefit and does not govern behavioral health services covered through managed care entities. And so I'm always trying to wrap my head around, is this a behavioral health benefit? Is this a medical health benefit? Who pays for this? Because it's EPSDT. And if you are a member of Denver Health, Medicaid Choice, or Rocky Mountain Health Plan Prime managed care entity, does this apply? And like, can you explain that provision? Because it's confusing to me.
Absolutely. And thanks for that, Rachel Entrican for the department. So I think two differences. This is not a behavioral health benefit. It is paid fee for service through Medicaid.
Okay.
So our regional accountable entities do not have a role in paying. However, you raised two good points for our full risk plans, Rocky and Denver Health. And I would understand, it would be my understanding that they would pay for these services as well. They are part of, covered benefits, and certainly for children and youth under the age of 21, these are available to them, whether they're in English care or not. Gina, did I get that right?
Absolutely, Rachel. Thank you.
Did that answer your question?
So point of clarification, I guess, it looks like this rule then does not govern behavioral health services covered under those managed care entities.
Rachel Entrican here. Excuse me, I'm so sorry. I'm just about to choke. You are absolutely right. So this rule does not apply to behavioral health services.
Okay. Okay. Gotcha. Okay. So, but not PBT service. So PBT services covered outside. Okay. It's just a very confusing part of this. So thank you. I think I understand now.
I appreciate that, Rachel Entrican again. I think one of the things that is very confusing is that we have behavioral health, right, mental health, substance use disorder treatment, and we have behavioral treatment for people with autism. And people with autism receive both, as do lots of other people.
Hi, this is Laura Carroll. I had a quick follow-up to one of the answers you gave on something else, Rachel, and then we'll move on. I thought I heard you say that we could recommend that this have a start of February 1st instead of Monday. And I'm not sure if I understood what you were saying there, so I want to make sure that I'm not the only one who didn't understand.
Thanks, Madam President. Rachel Entrican here. So I am proposing, given the concerns I think that we all share around access to care, that we amend the rule today to have a start date of February 2nd with the leave of the board.
Can you explain how that would work for simple people with lived experience like me who don't always understand all the weediness of it all, so that also people in the audience listening understand what we're thinking about?
Yes. Thank you, Madam President. Rachel Entrican again. So if you look at the language of the rule itself, and for folks who don't have it open in front of them, there is a header that says 8.281 pediatric behavioral therapy, and there is a next subheading 8.281.1 purpose. And then it talks about establishing standards for pediatric behavioral therapy. We could literally add the words beginning February 1st, 2026. This section establishes standards for.
Wonderful. And would you explain what the order of operations would be as president of the board if somebody wished to request such things so that I can make it proper and legit?
Madam President, could we pause for just a minute? Dr. Jastrzynski had her hand raised as well.
Oh, absolutely. I'm just trying to understand where we're going. I appreciate that 100%, and I can't see her. Thank you.
No problem, Madam President. Thank you. This is Dr. Jastrzynski. I just had a follow-up question to that proposal, which I think would alleviate a lot of our stress around this. What would that have an impact with what OIG is threatening to the state?
Madam President, Rachel Entrican, the answer is yes. It is possible that if OIG does not change its position between now and when they issue their final report, there could be another audit in the future of the money we are spending today, or the money that we continue to spend until the proposed date of February 1st. But it is a measurable risk as opposed to continuing with no place. Exactly. Yeah, with no rule in place. So thank you. Thank you.
Madam President, I have another question on a different line, so I don't know if you guys want to continue on the. Did you have a question about that?
Yeah, Madam Chair, I have another question on this.
Wonderful. Thank you guys. And I appreciate you guys taking the order when I can't see you. It helps me out a ton. Thank you so much.
For Ms. Intrican. So my understanding is that they would not consider this, say, 2 months in the same vein as their prior audit findings and just like lump $40 million more into this. And that I'm interpreting that you think that is unlikely.
Thank you for that question, Dr. Costello. These audits are retrospective.
Okay.
And so the period of time that they are measuring has already passed.
Okay.
Does that answer your question?
Yeah. But there would be a risk.
Yes.
Okay.
Go ahead in the room, please.
Madam Chair, this is Kathy Littler. It seems to me that certification is not regulated by DORA in Colorado. And so that's where we kind of don't have any understanding of how many technicians are certified and not certified. And it looks like the way that we figure this out in the future is that the company who employs them will do the background check and an attestation. And so when I look at the cost of this rule, it says really there's not a cost, it's a savings. But I'm wondering if there's any cost to the department to monitor who is registered and who is not, and auditing that to make sure that there's compliance with certification.
Madam President, Rachel Intrican, can I pass the mic to the policy specialist, Gina Robinson?
You may do so without asking, Rachel. Thank you, though.
Thank you, Rachel. Thank you, Madam President. So at this point in time, there was no cost to the department because we would look for those during any upcoming audits or audits that would be happening in the future, if those should develop. The other option that we could have that could put a cost to the department is to have all of those certified providers enroll in Medicaid. That is something that we have heard from the providers that they are not on board for. So that would be a discussion to have with those stakeholders in the future about options.
Any follow-up?
No, this is Cassie Littler. Thank you for that, Gina. I appreciate it.
Wonderful. Any other questions from the board?
This is James McLaughlin.
Hello, James.
Hey, Madam Chair, thank you. Anybody who's been to one of these before knows I spend a lot of time talking. This one I'm struggling with a bit, honestly. And so I've spent a lot of time listening today, and I want to start by saying thank you for everyone that's in here. And as I speak at this moment, I'm still undecided. I look at that map right there, and I can't help but notice that the area that I provide service for and the people that I'm responsible for sit in the part of that map that's covered by a lot of orange and a lot of red. And that scares me. Also, I appreciate the fact that we're talking almost 6 months now of notice. And I want to go back to what Mahoney said earlier. I'm responsible for the area I serve, and if I knew that there was a potential change coming, I gotta get ahead of that. That's my responsibility as a leader to make sure that my organization isn't where we are today, but where we are 6, 8, 10 months from now. And so with that said, it doesn't matter why we're here, we are here. And the potential is those services could be shut off tomorrow. And as the person that represents the 911 system, the people that everyone turns to when they don't know who to turn to, I know that's going to have an impact on my staff. I know that's going to have an impact on my community. That map reinforces that. And so my question is this, as a person who's thinking through solutions, the rural transformational funds, assuming we get some of that funding, one of the, and I believe it was the 7th thing that they talked about was workforce development. And would this not tie in with at least like the training and education for rural communities and getting that training and education out there, getting those people ready to do this work? I mean, obviously, we don't know if we've got those funds yet, right? We don't know if our application's successful, or I believe it will be, but I could be wrong. My question here is, and I'm nervous about pushing it back to February, but let's say we were to push it back to February. I think that to me sounds like the best balance of risk to meeting the needs moving forward. Could we use some of those rural transformational funds to ensure that the people in the rural communities get the training and education they need to provide these services?
Rachel Entricken for the department. Thank you. I really appreciate your comments and your questions. I think a couple of things. One, this is the first time I have seen this map. So I haven't had a chance to digest it either. And just for folks who are not in the room with us, we keep pointing at a heat map that some of the stakeholders brought in that is titled Workforce Shortage of RBTs, Registered Behavior Technicians, in Colorado, and it is broken into 3 categories: zip codes with either 0 RBTs, 1 to 9, or 10 plus RBTs. So I don't have a great insight into the workforce shortage. I do want to kind of try and untangle a little bit what we're talking about in terms of workforce and in terms of credentialing. Certainly, credentialing could slow down the increase in workforce, but in a way that, in our minds, I think we really do believe that it will improve quality. But I do think what this tells us is this is probably the exact same heat map we have for so many different kinds of providers in Colorado. I don't think we have the right people in the room to be able to answer your question about the transformation dollars. But what I can say is we have definitely seen this as an industry that is growing very, very quickly. There are private equity dollars that are coming in and supporting a lot of the efforts that these providers are making to increase the number of providers that are in the state. We see a lot of advertisements that are incentivizing bringing on new BCBA, so the individuals who are at that sort of master's level and above, and also asking for them to, and there being like bonus payments, those kinds of things for them to supervise RBTs, or rather BTs who are not yet registered. And so I think it's important for us to really be thinking about, yes, this is absolutely important. It is not, I don't want to conflate the 2 issues because it's not it's not an apples to apples comparison.
I appreciate that.
Thank you, Madam President.
Thank you very much. I'm still trying to figure out ways to make that map show up on my side, and I just couldn't It only is apparently working for some folks, but I did what I could. All righty. Do we have any other questions from the board?
Laura, this is Morgan.
Hi, Morgan.
So before we transition, I guess I would just, state from my purposes, to James's point, this is a hard one. I appreciate Rachel, the willingness of the department to, put a further deadline on the inaction of this rule until February. The retrospective component of that from a future audit would just say that if we're out of compliance, then that future risk grows during that period. I think from my perspective, it's hard to know what the impact of this is going to be because we don't know for sure who or who may not be, receiving services from this uncertified population. And so that for me is a challenging one. I understand that, this is a dramatic change and it feels very abrupt. I would argue that, again, I would agree with James as a healthcare administrator. If I knew that this was coming, I would have started getting my house in order on day one. And so I feel like, there's got to be a balance between, this has been a conversation for 5-6 months and pushing it out another 45 days is I think reasonable. I do worry about, these policies going into to affect tomorrow and what that means for folks who may be impacted and the level of uncertainty that parents in these positions may be put in. And I also understand the rock and the hard place with the department and the dire need to be able to access the matching funds. So, for the stakeholders in the room and all of those who received feedback or provided feedback, this is not uncommon for the Medical Services Board to deal with. We get some really hard stuff that comes through here, and we have competing and dueling responsibilities between the people who receive Medicaid services and making sure that everyone who receives Medicaid services isn't put at risk because of federal requirements or shifting landscapes or budget shortfalls. And so I just want to state for the record that, I guarantee that everyone on this phone and in the room took the time to read your feedback. We certainly appreciate and understand both sides of the equation, both from our responsibilities to HCPF and to our responsibilities of stakeholders. I'll just go ahead and state my position. I would support this because I understand the need from HCPF to address the audit findings and all of the things that Rachel and the staff have talked about. I would support it even more with a deadline of going into effect in February, just to give that one last 45-day window for people to get into this requirement category. So, Laura, just wanted to take a second and appreciate everybody for the feedback. Obviously, when stakeholder comments like this come in at the level that they do, we take it very seriously. We see how important an issue it is, and that's just an incredibly important part of this whole process. So hopefully we can find the middle ground and get to a place where we're both protecting the department and taking care of the Medicaid enrollees that are going to be affected by this rule.
Thank you, Morgan. Now all of you see why I sometimes I wish Morgan was still doing this job instead of me, and why his shoes continue to be so incredibly huge to fill. Thank you, my friend. Okay, do we have any other comments from the board?
Madam Chair, this is Cassie Littler. I just had a question about if the OIG final report says, yes, we have to pay this money back. Where does that money come from? Is that a retraction of payments to providers, or is that from general state funds? Where does that come from?
So, sorry, Madam President, Rachel Entrekin here. There are two different sources. One can be provider retractions, but that comes with appeal rights and with a long process that would include a lot of steps in between here and there. But the fastest retraction happens at the state level. So at the state level, we would have to return the federal share with state general funds within 1 year of discovery. 1 year of discovery in my mind would be the date that we received the draft fundings from OIG. So 1 year from this summer.
Thank you.
Yeah. You bet.
Madam Chair, this is JK.
Go ahead.
I just wanted to point out that I think right now we're talking about grace period for enactment of this emergency rule, right? But one thing I saw a lot in the stakeholder feedback is a rolling grace period, which I understand to be an ongoing 90 to 180 day period after hire, where people would be able to practice and be reimbursed. And I just want to state that I hear that's a difference. And for me, I don't think, given the emergency rule, we're in a place to work on that, like rolling grace period right now. And I just want to like confirm that difference and make clear that we're not talking about implementing that right now. Is that correct? Is that,
sorry.
I should have directed that to somebody.
My apologies. Rachel Intrican, thanks, Dr. Costello, for that question. You are correct. We are not talking about adopting a rolling grace period. This would just be a finite grace period right now to get us to February 1st. Really hopefully provide time for people who are in that credentialing process to finish their credentialing. The other thing that we're hoping is maybe we have a response from CMS or we have a response from OIG at that point, which could either give us clarity or could really reduce financial risk.
Okay, and then we could deal with that in the final rule in the winter, spring.
That is correct. So similar to Rachel Larson's earlier comments about pieces of this rule, you'll see have the word reserved by them. That is because we plan to bring those as regular rules anyway. So that is certainly something that we could add to that stakeholdering.
Anybody else from the board have any questions? Okay. I'm going to reintroduce my question with Rachel that we were talking about a little bit before. I guess it's kind of a question for the board, but I want her keeping me on the rails. Is the issue of the start date of Monday versus February 1st something that we need to ask the department to look at? I don't know how we really appropriately pull the crew. Rachel, maybe you can help me understand how we kind of go forward from here. If that's an issue that is holding people up, is not an issue that is holding people up. I want to figure out a best way to query the group and figure out where everyone is thinking on that.
Thank you, Madam President. Rachel Intrican here.
Yeah.
I can't actually see her. Thank you. Madam President, we're just going to move that map so that we can see the screen with you on it.
I love it. Thank you for that. I love that you guys put it there too. I really appreciate the out of the box thinking to at least let people see it. Thank you so much.
Thank you. So Madam President, I think there was a fairly straightforward way to do this. Rachel Larson on our team can add the language that I described into the draft rule. And then in the motion that the board would consider, we could add to the script. So what I'd like to do is read what that script would sound like with the additional language that we're proposing today, if that's all right with you, Madam President.
That's great. And then we will allow some opportunity for conversation if it's necessary. That sounds terrific.
I was wondering, we're going to have public comment, right?
Yes,
absolutely.
Of course we are.
Why don't we do that
I'm just
before
trying
we
to
talk
get,
about it?
I'm trying to get my ducks in a row so I can sound like I know what I'm doing at this job. You know what I'm saying, JK?
Yes.
Okay, so I'm not going to read the whole motion. Madam President, I'll just read the added language that would go at the end of the motion if the Medical Services Board wants to move forward with a vote today with this new language. And that would be, sort of the move the emergency adoption of document, fill in the blank, with the newly proposed amendment to make 8.281.4.A.4 effective February 1st, 2026. So it would not require a complete overhaul of the documents that we have.
That's what I was worried about. Wonderful.
Thank you,
Okay,
Madam.
so we have that kind of spinning in our stratosphere now too. All
And
right.
I have, this is Kathy Littler, sorry, I have a point of clarification on the emergency adoption.
Please.
If we, Rachel, if we put a effective date of February 1st, does the emergency adoption end 90 days after today or 90 days after February 1st?
Oh, yes, point of clarification, Rachel Entrican here. It is actually, emergency rules are effective for 120 days,
Oh, sorry.
not 90.
Sorry.
So I'm sorry, and I think that
Thank you
was
for
just a
that.
point of confusion
Yeah,
earlier. And I actually need to phone a friend here. Okay, my friend has already responded. So it would be 120 days from today's date.
Okay.
Do I have any other questions from the board? Barry, I saw you come on camera. Were you wanting to say anything? No, thank you. All righty, let's start working on public testimony here. Mr. Sykes, I know you have that list in front of you. Did you have somebody you wanted to start with? How do you have stuff set up on your side, Mr. Sykes?
This is Chris Sykes, Madam President. I'm looking at the same list you are looking at, so.
It's
I
quite a
will
list, Mr. Sykes.
I will punt to you and ask you how you would like to do this.
All right, well, okay,
Madam
guys.
Chair,
Yes, please,
this is
James.
I don't want to miss any of the testimony, and I would love to maybe consider taking a quick 5-minute break before. Would that be okay
I'm
or no?
happy to oblige a 5-minute break. Let's do it. 5 minutes, team.
This was
That's time, everybody. Hello, community. Hello, community.
Hello, Laura.
Hi, David. How are you?
Great.
You
Let's
think
get this thing party started.
I'm a trying, brother friend.
I know. I know.
Hello in the conference room. Can anybody hear me?
Yes, we can.
Wonderful. Thank you, team. Okay, so what we are going to do with public testimony, because there are so many people signed up, as I mentioned at the top of the meeting, is that we're going to start by picking one person per organization. I have some notes here. It looks like maybe some folks have asked to be the ones. Gonna try and get through this as best I can. I am looking for grace, assistance, all the good things. So Mr. Sykes, do you want me to pick the first person?
Madam President, this is Chris Seitz. I would be supremely confident in you selecting.
Watch you pass it. I'm watching you pass the buck to me, Mr. Sykes. I'm gonna remember. All righty, so I'm doing this alphabetically by organization. The first organization that I show up on the screen is Action Behavior Center. And the first person I have up on my list from Action Behavior Center is Jenny Snyder.
Calm down. Sorry.
I think we're going, I'm Jenny Snyder. Hi, everyone. I think we're gonna have a delegate from our organization. So if I can pass the mic over to Brian Davey, that'd be awesome. Thank you.
Sorry, I could not hear a word of that. My apologies.
Madam President, we have a delegate coming up from Action Behavior Center. He's coming to the mic, right?
I love that. Thank you guys so much. Okay, so what we're gonna do is we're gonna put, what was the name of this person? I'm sorry.
My name is Dr. Brian Davey. I'm Vice President of Public Policy for Action Behavior Centers.
I just wanted to find you on the list so that I can mark you off, Brian. I appreciate you very much. Okay,
Thank you.
We're going to put 2 minutes on the clock, and we're gonna let Dr. Davey give us a talk. Go ahead, please.
2 minutes. I asked you for some grace because 3 minutes on the agenda and then having to be the spokesperson is a lot of pressure. My name is Dr. Brian Davey. I'm a nationally certified behavior analyst and currently Vice President of Action Behavior Centers for Public Policy. I appreciate the opportunity to speak to you today. First off, ABA providers fully support the goal of ensuring technicians ultimately become certified RBTs. However, the community respectfully requests for that rolling grace period that allows behavior technicians that have completed the required training and demonstrated competency to continue providing direct therapy under the supervision of a board certified behavior analyst. You guys speak about the need for numbers. There's 8,000 techs out there right now, 6,000 of them are RBTs, 25% of the workforce is in training. We can't hire people fast enough to meet the need. So when you say, are you up there and being prepared? In the last 4 months, 1,000 RBTs have come into the system. The organizations are working as hard as they can, but we cannot match the need. The rule is currently written threatens to limit access to medically necessary services for children with autism and risks causing long-term harm without timely and appropriate PBT services. Many children will need more intensive services through special education, medical care, and adult disabilities. I'm going to skip now to something that is my most important point. The state is asking you, the Medical Services Board, to eliminate this long-standing grace period effective today, or now you're talking about February, citing a CMS approval requirement that does not exist. HCPUF has repeatedly and incorrectly asserted that the OIG requires RBT certification. That is misleading. No federal law, no rule, regulation mandates RBT certification. As we disclosed to HCPUF and their attorneys this week, providers reached out to OIG regarding this issue. We actually had a response in 48 hours from the Deputy Inspector General of Audit Services himself, John Hay, who told us he would be very interested once the report comes out or this adoption of this rule comes out to talk about the lack of access to care that this could create. But most importantly, his correspondence explicitly stated, and we shared this with the state, states have policies, have different policies as it relates to grace periods, as you saw, for certifications for autism service providers. establishing or revising such a medical policy falls under the
Doctor, I'm
purview of the
sorry
state.
Doctor, I'm sorry, that's time. We so appreciate your time with us today. Do I have a response from the department?
Yes, please, and thank you, Madam President. This is Rachel Entrican for the department. Dr. Davies, I really appreciate your comments.
Sorry I had to go so fast.
That's okay.
I didn't even get through it. I was trying to get to all, and you guys had such good questions that I wish we were up here as subject matter experts to answer it for you.
We are
Rachel,
prepared to ask and answer you questions, sir, but we do have to start with the 2 minutes for you to make your statement. I promise we're going to have questions for you.
Thank you. I may phone a friend.
You bet. Go ahead, Rachel.
Thank you, Madam President. Rachel Entrican for the department. Dr. Davies, I think there is some confusion. I understand that COABA reached out, or COABA's lawyers reached out to OIG in the last couple of days to ask for clarification, and that is a lovely thing. You have gotten clarification that we do not have. We have not heard it from the horse's mouth, and in fact, what we have heard is exactly the opposite. We have OIG telling us that the money that we have paid for uncredentialed behavior technician time is not covered by federal Medicaid dollars. So this puts us in a really terrible position. I hear your frustration. I am also frustrated. And we don't have the clarity that we need to be able to move forward with a rolling grace period or a grace period of any kind, frankly. We are doing the best that we can in limited circumstances. The other thing I really want to be clear about is, I think to the provider community, and boy, do I understand this, it feels to you like we have had a long-standing grace period policy. That is absolutely not true. We learned about the lack of credentialing when we received the OIG report back this summer. So I think that there's a little bit of a disconnect there too. What we are asking for is for the credentialing that I think everyone agrees is a good thing. I didn't see one stakeholder letter that said, hey, to heck with credentialing, we don't want to do it. That sort of assurance of quality is so important, and the assurance of kind of a standardized curriculum. So I do just want to make very clear, I understand you have conflicting information. We have not heard that back from OIG in any way, shape, or form. And so acting on that now would be irresponsible. Thank you. Madam President, back to you.
Thank you very much. Do I have any questions from the board?
Madam President, this is Kathy Littler.
Go ahead.
I hear that we have conflicting information. I'm wondering, Rachel, if we know when we'll have actual stated clarification from the OIG, if there's a time frame or a timeline that would coincide with, this kind of definitive grace period that we're maybe discussing, right? That then the department could work on a rolling grace period, if that's something that's potential.
Madam President, Rachel Entrican for the department. We do not know either when CMS will get back to us with clarity or when OIG will give us their final findings. What I can tell you is that we are in the process of submitting our response to the OIG report, which we also can't talk about. And then after they receive our response, they have a period of time to look at it, which also can come with extensions of time. So it's really unclear to us when we will hear. I think part of the delay, frankly, has been the government shutdown. So there were questions back and forth and then a pause.
Did that do it for you?
Yes, Madam President.
Wonderful, thank you. Do I have any other questions from the board?
Laura, this is Morgan.
Hi, Morgan.
Morgan Honey. So Dr. Dave, I believe it was Dr. Davey. I would just like to, kind of put this on the table. So it sounds to me like your comments are more of a conflict with both official and unofficial word from OIG. And I think that that's an important clarification. The department is working against, working with information that they have through official capacities with the federal, with their federal agencies. And that is what you see on the table here today. Point of clarification for Rachel, I suppose. No, I'll hold that because I don't want to open that can of worms. So just stay for the record, the rule that we have in front of us today is indeed a response to official notification from OIG. I would ask what Rachel's course of action would be coming out of this meeting between now and the January meeting of the Medical Services Board, and I know I'm asking you to read a crystal ball, but what do you expect to hear from OIG that could impact, this particular rule between now and the next MSB meeting based on Dr. Davies' comments?
Yeah, thank you, Mr. Honey, Rachel Entrican for the department. I think certainly what we were hoping for is a swift resolution of the portion of the audit that deals with uncredentialed technician time. I don't know that we will get it though, and that's the crystal ball piece. There is really no way for us to rush the OIG or to rush CMS to give us a response. We ask questions and they get to us when they can. I know they have a lot going on as well, but this is a really important question. Certainly what we can plan to do, if the board desires, would be to update the board on the record at our next MSB meeting.
This is Morgan. I think that request goes unnecessarily stated. And then secondarily, I would say, Dr. Costello made a very important point that the rule on the table today is as is. And the issue, again, that we saw time and time again in the stakeholder feedback is about the ongoing grace period. And so in my mind, those are two separate issues, one of which is not being addressed in this rule that needs to be addressed based on the table that you guys showed us with the different states. But that's not what we're discussing today. So just point of clarification and good call out by Dr. Costello.
Madam Chair, this is Kathy Littler. I have another question for Dr. Davies.
Yes, ma'am.
I wondered if you could help us understand for Action Behavioral Centers how many registered behavioral therapists or technicians, that you have versus how many that are in the process.
I would say on average about 25% at all times. So Action Behavior Centers is a large multi-site ABA program here in the state of Colorado. And we are probably hiring at a clip of around 100 people every single month to meet the need of both the commercial and Medicaid side of this epidemic. With that, RBTs don't just exist in a vacuum. I cannot go and put out an advertisement to hire one who already has that certification. We have to take them from whatever, working at Starbucks, working at McDonald's, wherever they might have been previously, and get them through 40 hours of training and competency plan. Once we get them to that point, we then have to go through the administrative part of getting a credential, which is lining up all of our information, putting it into the portal for the national certifying body, getting a testing exam site. There's 2 Pearson sites in the entire state of Colorado. So this impacts definitely the rural areas in a very significant way. And while they may have less RBTs and behavior techs to deal with because of population, we'll still have to deal with this rule. They will still have to go find people that are willing to take this job, go through this training, when they could choose from any other job that might be out there that probably pays more and is a heck of a lot less stressful than working with children that are in need of both behavioral remediation as well as skill acquisition approaches. So I'd say ours is around 25% at all. So that's the reason we asked for that rolling grace period, which I understand is not part of the discussion today, but it needs to be, because without that, you are choking off access to care. And I do want to state again, all of Colorado's ABA providers have been responsive to this pending rule coming. We are going as fast as we can. Nobody's sitting back saying we're not going to do this. The reality is that growth in this and need around this is always going to have this group of people that need to have 60, 90, 120 days to get there. Action has its own internal policy that if you can't go from being a tech to going through that 40 hours and getting your competencies to getting your RBT, after 120 days, you are no longer employed with us. Many other providers have similar things. We want them to be certified, but you're asking us to jump through a hoop that we cannot reach. It's like asking me to slam dunk a basketball. I cannot do it. No matter what you offer me or what you threaten, you can barely get a credit card underneath you, right? We are going, like, as a provider community, the reason you have all these people here today is because we work with these families day in and day out. And understanding that you'll quickly move, like hearing somebody say, oh, just move technicians around. These technicians work with these kids and know these families for 8 hours a day and 5 days a week. Just shifting people around threatens continuity of care, threatens clinical outcomes, quite honestly is disingenuous to the kind of treatment these families deserve. And so I appreciate that question, and I hope that I answered it clearly and concisely for you. And I'm happy to provide you exact data if that would be helpful to you as you make this this decision.
Thank you.
Thank you.
Do we have any other questions from the board team?
Yeah, Madam Chairperson, I have a question for Ms. Intrican and for Mr. Davey.
Go ahead.
Doctor. Ms. Intrican, question. I realized during this testimony, I may have made this up, but I heard a conflation of two things. One, that there were services the department should be paying for, sleeping, play, and that the department was told not to pay for uncredentialed therapy. And we just want to clarify, those are two separate critiques, and I realize there's things you can't reveal to us about the OIG, but just wanted to clarify those are two separate items that they've said. Yeah, so they said you can't pay for uncredentialed treatment therapy, and there were things that you pay for that you shouldn't have paid for.
Madam President, this is Rachel Intrican for the department. You are correct. So these are different issues that all added up to a single dollar amount finding.
Okay.
So some of those issues were about a third were the uncredentialed technician time. And then the other 2/3 had more to do with either poor record keeping. And granted, this is a sampling. The feds can sample, we do not. So what they looked at was a number of records, and they looked for several things. One of them was documentation adequate that was produced. One of them was were the items that were billed for truly covered under Medicaid policy, and then the third was technician credentialing. So I don't know if it works out to be a third, and a third, but certainly on the technician side, that was about a third of the findings. And it speaks to, I think, what you were talking about. Either there were documents that were missing, or there were kind of carbon copies of treater notes that would sort of be the exact same one day after day or week after week. And then there were a lot of things that I think were perfectly fine. So, certainly we're focusing on what the findings were, not sort of OIG doesn't come to us and say, hey, your technicians are great. Good job. You're doing a fabulous job. They're going to come tell us what they're not happy about.
And one more, person. Dr. Davey, what's the ownership structure of Action Behavioral Center?
Action Behavior Center is private equity backed.
Right, multi-state or just here?
Multi-state. Yeah.
Thank you.
And I would just add to that, there was a discussion around rates, and I have some of the people speak to this, so I'll just give you the primer, that there was several years ago where rates were drastically cut, and organizations, I believe COABA, somewhere between 12 and 17 ABA organizations completely disappeared from your state. Organizations like Action are in a particular situation where they can weather storms like that and continue to provide services in distressful situations around rates. Not everyone can do that. So having the ability to have a mix of providers that are both privately held as well as private equity backed is critical to maintain the system.
Thank you.
If I may, Madam President.
Please.
Rachel Intrican for the department. I do want to clarify. I think Dr. Davey raises an important point. Rates were reviewed in 2023 and were increased by a pretty significant amount in 2024. There have been some rate adjustments sort of across the department with the budget crisis. But the rates that PBT providers are paid today is much, much higher than I think when Dr. Davies referring to.
Yes, if I can add to that.
Sure.
So two things. One of the reasons you increase rates is because you want to be able to attract providers to your state. We are still not even to the point of where we're able to attract, given the rates we have today. I would also say that rates have been increased. There's current discussion of rates that are being cut, even though that's not the discussion here. I will tell you, it would take us back to rates of 2019. And so all of this back and forth in terms of rate cuts and increases and decreases, today what's on the books and that they refer to as pending litigation is around us going back to rates that are 6 years old in the Medicaid business, which is difficult to swallow for most, and if not all, of the providers you have sitting in this room.
Laura, this is Morgan.
Go ahead, Morgan.
Dr. Davies, so you mentioned that you take care of both commercial and Medicaid patients. Can you estimate kind of what your payer mix is, and then how what we're talking about today either aligns or is unaligned with the requirements that you are working against in your commercial line of business?
Yes, I would say that, and you cannot hold me to this number, and somebody may correct me that's going to speak after me, but about 30% of our business is Medicaid in the state of Colorado. The requirements of having an RBT status on day one, that is not something that we see in our commercial contracts. Optum, which is part of United, the largest behavioral health provider in the country, allows us to have a grace period to get people up from when we get them through their 40 hours of training and their first competent exam to get them that certification. And that is the process that we work with under our commercial payers in the state as across the country.
Thanks, Dr. Davis. This is Morgan. So just follow-up question. It would be nice to know or helpful to know kind of a side-by-side comparison of what is that grace period or those requirements that you're already managing on the commercial side, and see how they, apples to apples compare to, what we've heard in the testimonies.
I can't give that to you right this second, but I would be happy to present that back to the Medical Services Board as early as next week.
Yeah, I would say, this is Morgan again, just send that to Rachel.
Yeah, happy to send that to you, Rachel.
Thank you very much, Dr. Davey. Madam President, if
Point of order, if you could please send that to Mr. Sykes, and that way he sends it out to the entire board. Thank you very much.
Thank you, Mr. Sykes.
Madam President, if I may, Rachel Entrican here.
Please.
Thank you. I do just want to raise 2 points that I am a little confused by. So under Colorado State Statute in Title 10, which is our private insurance statute, registered behavior technicians are required to be credentialed before their services can be charged for. So I'm a little bit confused by the statement that, and maybe you weren't talking about Colorado. It could be that I misheard. Are you saying that in Colorado, private insurers are paid for a grace period?
I'll defer to, I'll find a friend on that, but I believe, yes, they absolutely are. Interesting. And that rule that you bring up, I want to make sure we're clear. I think it's CRS, I forget what it is, you rattled off as part of your presentation, does not apply to Medicaid program in Colorado. Okay?
I agree 100%.
I just want to make sure that we're very clear that that is not the basis for this rule.
I agree 100%. It's CRS 1016-104. Talks about mandatory coverage provisions for autism providers, and the qualified autism providers include only credentialed RBTs in the technician category.
Madam Chair, I'll let somebody else who's much more versed in that.
Okay, that would be great.
Sorry, I couldn't hear it. I heard Madam Chair, and then I heard nothing else.
Madam Chair, we'll have a subject expert give with Mr. Sykes and Rachel to get her that information.
That sounds wonderful. Thank you for doing that. All righty. Do we have any other questions from the board?
Madam Chair, James Gilmore.
Please.
So Dr. David, thank you for your testimony, and thank you for addressing some of the questions that came up prior to your testimony. I really do appreciate that. I am definitely trying to struggle through this. I also can empathize with a lot of what you had to say. as somebody who provides EMS in a rural community, every single time one of our ambulances rolls out the door, our cost is $1,900. And every single time we build Medicaid, if we're lucky enough to build medication, because we don't get paid if we just show up and provide care on scene. We only get paid if we take them to the most expensive destination, right? And when we transport them to that destination, we only recoup about $200. So we lose $1,700 every single time we transport a Medicaid member. Absolutely understand the frustration. Also, we have to, every single time we bring on a new person who's gone through 2 years of training and education, they come in, they have to work as a third person on that ambulance for up to a year before we can then take that third person off and they can work independently on that ambulance. So we invest an additional 12 months of cost into that person and recoup absolutely zero revenue from that person. And we're a small organization, right? Like we're a small community organization, and that's happening all over the state of Colorado. And so one of the things that we look at is that's an investment cost, right? We're investing in the future and we need to know what the return on that investment is. I'm guessing you probably do have those numbers for your organization. What is the cost of getting a person trained and ready to go? And how long does it take you to recoup and recover that cost associated with that?
I love that question, but there are people much more, I'm a clinician by training,
No, you're
not an operator. So I'm gonna defer, please, can we put a pin in that question and let one of the other representatives that will speak to you handle that?
Absolutely, I would really appreciate it, because that helps me understand, like, you know, you're taking a risk. Not every single person you train works out.
Yeah.
It's not the right job, the right fit for everyone, right? Yeah. So, and I would really like to understand, what are those costs and how long does it take for you to recoup those costs?
And let's be honest, right? You could take commercial insurance that pays much better rates, not as many rules and regulations, and not serve Medicaid families. The organizations you have here represented today are investing in Colorado by maintaining their ability to serve those families. I'll let them speak to the numbers in the future. Thank you. Thank you for your questions. Thank you for your service.
Dr. Davy, is there someone in particular you want me to call on next so that I can?
I think people may just want to raise their hand, Madam Chair.
That does not work when I am this far away. We also have a list of people who are signed up for testimony, and we maintain order in this outfit.
Madam
So,
Chair,
is there one person in particular you'd like to go right after you from your organization? Otherwise, I'm going to go down the list. I am trying to make this better for you.
Yes, Madam Chair, we have several people from our organization that will be adding different points than what I made. And I would respectfully ask that you hear from them for a few moments as well.
Great. So there's not any one person in particular you want to come after you to address that particular issue you were discussing?
No, I'll let somebody else handle that probably from a different one.
I'm trying to give you as much space as I can to give us as much information as you can.
I appreciate it, Madam Chair.
No problem. So do we have any other questions from the board from Dr. Davy? Hearing none. Doctor, thank you for your time. Thank you for coming in person to share. So what I'm going to do now is I'm going to start hitting the next people who work for the same organization. I'm going to state your name. If you have more to add to the conversation, we are excited to hear from you. If you just want to add on to exactly what he's saying, I'm going to ask you to be respectful of everybody's time and let us know that Dr. Davy got it for you, and we will keep going from there. So the next person I have on my list from Action Behavior Center is Jenny Snyder. Jenny, are you in the audience?
Yes. Would you like me to come over there?
Please. That way I have the slightest chance in the world of maybe seeing you.
I'm on my way.
Thank you so much. I appreciate you.
Okay. I definitely would like to be respectful of everyone's time, so I'll condense down what I brought today. But my name is Jenny Snyder, so nice to meet with all of you. I am a regional director of operations at Action Behavior Centers. The additional context I feel I have to add is just ABA therapy is life-changing. I'm talking patients speaking their first words and sharing toys with their peers and connecting with others for the very first time. And these moments are nothing short of life-changing for the families that we serve. And I very much recognize here today that not everybody has the privilege of being part of that work. And I understand we all are parts of different work, but just wanting to recognize the fact that I know if you could have firsthand experience doing this work, I have no doubt you would understand why our request today is so important. As has been mentioned already, we're not opposing the RBT certification requirement. We fully support that. Just wanting to add that during patients' time at our centers, we're helping them build the communication, social, and daily living skills that often make it possible for them to enter and succeed in the school system. And in many cases, ABA is the reason a child is able to step foot into a classroom for the very first time. And that's super important and impactful. I think we could all agree on that. Last, to close, since I promised I wouldn't take all of the time, I think a great call out is just that I heard a question asked a lot earlier about, if not with us, where? We don't know either. So I think that's important to say, that if they're not coming to us and if we're not given this rolling grace period and that our answer is we don't know what happens to these patients either. Thank you.
Thank you very much, Jenny. Do we have any questions from the board?
Madam Chair, this is Dr. Manischewski. I have a question.
Thank you. Go ahead.
So my name is Dr. Schlinke. I'm a pediatrician. I diagnose kids with autism probably at least once a month because I do my own evaluations. So I just want to clarify, while we all come from different experiences, there are some of us who work intimately with kids with autism every day in their offices and with your organization referring patients to you for therapy. And I do know the impact that therapy has on kids, and I do see it. And honestly, a lot of my time is spent trying to get my families to connect with a therapist, get them enrolled, and get them started in therapy so they can have the benefits you mentioned. I want to be clear of like our responsibility and also our limitations as board, because we stand with Medicaid patients and we stand with the kids. We want them to get the services they need. We also don't want the loss of federal matching dollars to cut at the knees Medicaid payments of all kinds, not only for kids, but also vulnerable adults in Colorado. I want to clarify, my clarifying question, Madam Chair, is with this request that keeps coming up of rolling grace period, which I want to reiterate, I don't think we can address today because it's not within our bounds. Even just so that I can put this issue to rest in my mind, right? Even if Colorado was to have such a grace period, there is a potential that we would have to entirely pay for that out of state funds, because at this point, our information is that OIG would not match the funds for not certified providers, in which case it would be a matter of our state legislature, our representatives, to vote on, because it would be a budgetary issue. Am I understanding that correctly?
Madam President, Rachel Intrican.
Well, Rachel, thank you so much, because when she said Madam Chair, I was like, yikes.
I'm sorry, Madam Chair. I apologize.
Yeah, Madam President, Rachel Intrican. With the caveat that I am a lawyer and not a finance expert, my understanding is you are correct. There would have to be a few steps, right? So the official message that we have from OIG right now is those services, meaning uncredentialed behavior technician services, are not eligible for federal matching dollars. That's what the draft audit report tells us. So until we have clarity one way or the other, then yes, we are risking state funds only to pay for those services. You know, at this point, certainly the state legislature would be able to tell us whether or not we had spending authority to spend state funds only. And that is usually how our state funds only programs work. Is the General Assembly and they're the people who have the power of the purse. They're the ones who tell us yes, we, the legislature, are making this program go forth and administer it. And at this point, we don't have that explicit authority. Thank you for that answer.
Madam Chair, James McLaughlin, can I just seek one point of clarification for slower people like myself? So I just want to, so if one of the routes for that would be, if somebody was interested in having that funded, they would need to go out and find someone to sponsor a bill and have that bill introduced, and or
we would, oh, sorry, Madam President, Rachel Entrican, or we would have clarity from CMS or OIG, which we just don't have yet.
But that is a course that's open for anybody that is really passionate about this. If they wanted to find it, they could go and make their case through the legislative process, and if it made it through that process, then it could get funded. But yeah, I appreciate it.
Do I have any other questions from the board? Hearing none. Thank you very much, Jenny. We appreciate you. The next
Thank you for your time.
Anytime. The next person I have on my list is Lucy Jones. Lucy, are you in the audience?
Hi, yes, I'm here.
Wonderful. Did you have another thing? Did you have something else to add, or did you wish to just agree with everything that's been said?
Yeah.
Which one?
Hi, yes, I have something to add.
Oh, very good. Okay, let's get 2 minutes on the clock for Lucy.
My name is Lucy Jones, and I'm the operations manager at Action Behavior Centers in Brighton, Colorado. I started my career in ABA 3 years ago as a behavioral therapist and had the opportunity to grow through the amazingly thorough process to become a registered behavior technician in the state of Colorado. This process included completing the required training by an RBT trainer, shadowing tenured RBTs, passing a competency assessment led by a preceptor, and being supervised by a BCBA while providing direct therapy. All which led me to passing my RBT exam and becoming certified in Colorado. I went through this extensive but necessary process to become an RBT. I was able to provide medically necessary therapy services to our patients. The progress witnessed for patients during that time was inspiring and really what gave me the drive to become certified. If I was not able to provide services during the time, therapy sessions could have been canceled, leading to patients not receiving medically necessary treatments. Their families would have been without support needed, and we could have seen regression in social and language skills and their day-to-day progress to become more independent. All of these scenarios and potential regression will become a reality with the emergency rule requiring immediate RBT certification without a grace period. And I realize that's not what we're talking about at this moment moving forward as well. Though that's while we support the intent of the proposed rule and the RBT credential as a long-term standard for our workforce, the grace period would allow the trained competent therapist like I started off 3 years ago to continue providing the care under BCBA supervision, just as other fields allow as well. So a short grace period would avoid a staffing crisis for providers in the state of Colorado and could be the difference in a child's ability to become more independent in life. So I went through this process myself, and I definitely had the support needed to provide that medically necessary therapy and the quality care that my company definitely requires for each student.
Thank you so much. Do I have any questions from the board? I see you,
Madam
James.
Chair, thank you, Madam Chair. Thank you. Actually, lived experiences are very important to me and probably to most of us here on the group. So I'm really glad that you took the time to come here and share your experiences with us today. And so I have a couple of questions. Could you walk us through quickly kind of what that training looked like for you, the steps you took? And then would you have an approximate idea on what the cost of that would be if somebody started it today?
Yeah, so I can walk you through the process. I don't have the approximate cost. I started off day one, 40 hours of training modules with an RBT trainer in a specific training site, which is what we still require to this day. And the 40 hours of training modules takes about a week and a half to get through, because there's also some guided practice in there in between. And then from there was in my home center to shadow tenured RBTs and to be supervised by a BCBA. I had to pass a competency assessment, which was a verbal and a physical competency during that time. So verbal, what does this mean? What does that mean? Physical, on the job, real time, direct therapy with a BCBA supervision. And then from there, I was allowed to provide direct therapy to kiddos who are covered by Medicaid. So from there, I had to apply to the BACB to be able to sit for the test. And then I actually had to pass the test after that. That took me personally about 42 days to get through that entire process. So that is a number that I have, but I don't have the cost of it.
Yeah. No, I appreciate it. Thank you very much. That's all I have, Madam Chair.
Thank you, James. Do I have any other questions from the board? Hearing none. Lucy, thank you so much for your time this morning. We appreciate you. Let's see. The next person I have on my list from Action Behavior is Morgan Micheli. Did I say that right, Morgan? Are you in the audience? Do we have Morgan?
In the audience, I believe we are deferring to me for the sake of time, we picked 3 that we felt like had the points necessary, so to get across to you all, so Maddie's gonna go next to that. Perfect.
Thank you so much. What I want to do is I do want to read the names of everyone else who came out, so we've got them on public record, okay? And I'm going to do my best. If I abuse your name, I apologize. So we had Morgan Micheli, Catherine Etkin, Selena Cox, Samantha Dolphin, Audrey McIntyre, Rebecca Chase, Phoebe Smith, Martha Allen, Hannah Zara, Heather Henderson, Lucy Jones, Olivia LaForest, Tyler Johnson, Hannah Gleason, Elizabeth DeWolf, Madeline Cooper, Reese Salmonson, I'm so sorry, Reese, Samantha Dolphin, Melanie Marshall, Nicole Rayner, Andrea Myers, Kathleen Zdenek, again, sorry, Kathleen. That is everybody who showed up from your team today. Thank you so much for taking time out of your day so that we could hear what you had to think. We will now move on to the next folks. Good morning, Bryce Rafferty with CCDC.
Okay, Madam President, this is Chris Sykes. I apologize. Yeah, no, so what Action Behavioral Centers is proposing is that they're willing to speed all of those individuals, and they would just like to propose 3 individuals come forward at their selection to provide different testimony.
So 3 more folks.
Yes.
Okay, I totally misunderstood that. I am so sorry, team. And that's why it was so important to me to at least say everyone's names, because it matters so much that you guys showed up, and we don't want to cut you short. So we have 3 more, and you guys are going to tell me who they are and carry on from there.
Yes. Good afternoon. My name is Madeline Cooper with
Hi,
Action
Madeline.
Yes. So thank you so much for taking the time to hear us today. I currently serve as a family advocate with Action Behavior Centers, but my career in ABA actually began 5 years ago as a behavior technician uncertified. When I entered the field, my training included 2 weeks of classroom instruction for the 40-hour RBT requirement, 2 weeks of shadowing experienced clinicians in the center that I was going to practice in, as well as a verbal hands-on competency assessment with a BCBA before I ever took an independent session of direct therapy. I began providing supervised one-on-one sessions following that competency while waiting about 6 weeks to be able to sit for my assessment, which included the approval time as well as a testing site to become available. Those supervised hours were essential. Without the opportunity to apply my training in real time, I would not have been as prepared to pass the RBT examination on the first attempt or to provide high quality, safe, and effective care. During this time, I received the same level of supervision as my credentialed peers, and that support strengthened my skills, confidence, and ability to manage crisis situations and support meaningful progress of children on the autism spectrum. This change would take away critical learning opportunities from individuals who have already demonstrated competency and are delayed by factors outside of their control, such as testing availability and application processing. In addition, it would slow providers' ability to start Medicaid services and could disrupt care for many children currently receiving treatment despite strong evidence that continuity is essential. And so just to end, I side with Mr. Davey or Dr. Davey in regards to the need for a rolling grace period, which I know we're not discussing today, but just wanted to provide you my example, my real life example of what that process looked like and the delays that I saw and how this could be detrimental to our community.
Thank you very much. Do we have any questions from the board?
Madam Chair, this is Dr. Dushansky. I have a question.
Thank
And I
you, go ahead.
apologize if this is not appropriate for you in particular, but maybe for the community gathered here today. So I'm a physician and we have folks of different training backgrounds but a lot of folks who've worked in healthcare in different capacities. And what I hear you saying is that during the point of your training, you received the appropriate supervision, which is awesome. But your company was also paid for the work that you were doing by Medicaid. And I guess my question is, and this is not, maybe there's no answer, but something that I think the board should ponder, is the fact that there are folks who do training and do not get compensated for their care while they're getting trained, like medical students. They paid to be in school at that time and see patients during their 3rd and 4th year. They do that under the supervision of a physician, but I don't get paid by the state for my medical students' work. And there are other folks in other technical fields who take care of very needed patients, and during their training period, they also don't get paid for their work. So I recognize the shortfalls that we have in care, whether it's in EMS, whether it's in physicians, whether it's in therapists, whether it's in behavioral health providers. And I recognize it is an enormous crisis, not only in Colorado, but across the country. I guess I wonder why this particular field would be treated differently.
That is a fantastic question. I do believe that there is somebody who is after me on our list that might be able to better address those questions for sure. Yeah,
I appreciate that. Thank you.
Do we have any other questions from the board?
Yeah,
Thank you
quick
for-
question. Sure.
Go ahead, JK.
What's the average pay for RBT?
I believe that varies by state. I believe that our operational leader is next, so she will have the exact amount. About $20 an hour.
That's the difference.
Thank you so much. We appreciate you taking time out of your day today to come sit and go through the process with us. Thank you so, so much. Who do I have next on deck? Hi, good morning. You can look straight ahead. And if you could please state your first and last name so we can get it on record.
For sure. My name is Melanie Marshall.
Hi, Melanie. Good morning. We'll put 2 minutes on the clock for you.
Great.
Off you
Start
go.
when I'm ready?
Off
Cool.
you go.
So my name is Mel Marshall. I'm the Regional Clinical Director for the Denver Central Region of Action Behavior Centers. I'm a board certified behavior analyst since 2019, and I've been working with this population of children and adults with developmental disabilities since 2005. I'm also the mother of an incredible 6-year-old, and she has her own unique blend of neurodivergent herbs and spices herself. My role as a BCBA is never just the practitioner of behavior analysis. My role is often therapist, confidant, mentor, teacher, cheerleader, and a void to scream into. I've held parents' hands and offered soothing support as they grieve the future for their child that they daydreamed of since their child's early infancy. I've served patients on the other side of the service cliff where early intervention and school-age resources run out and opportunities for treatment into transitional years and adulthood are already scarce. I'm not a stranger to the feeling of hopelessness and helplessness that accompanies a family losing resources or security to their child's care. As someone who's been doing this for a long time, I can tell you the fewer resources we have, the fewer resources we have. Diminishing the workforce begets diminishing the workforce. Behavior technicians, BTs, receive the same training as registered RBTs, as well as the same amount of supervision from a BCBA. It's the same supervision, it's the same training. And to further address the question of what happens Monday, these children will end up in emergency rooms. Families will be calling 911, and the caregivers are going to have to be removed from the workforce to care for their children. There are no other comprehensive evidence-based treatment options for the children with autism that we serve. As a parent and as a behavior analyst, I just implore our decision makers to engage in the same compassionate care values that our BTs, RBTs, and BCBAs are using every day with some of our most vulnerable citizens. Thank you.
Thank you very much. Do we have any questions from the board?
Madam Chair, James McLaughlin here.
Go ahead, James.
So you are that, I just want to make sure, your area, you cover Colorado.
I cover Denver.
The Denver, okay.
Yeah.
Your organization on that map, without obviously disclosing specific patient information in any way, shape, or form, what areas on that map do you guys currently provide coverage? If I was to call or a client was to call and ask for services, what areas would you guys cover on that map?
Action Behavior Centers is as far north as Fort Collins and as far south as Colorado Springs.
Okay, along the I-25 corridor, how about east and west?
East and west, we are Lakewood to Aurora. Huh? Green Valley Ranch.
Okay, and then if the client fell outside of those areas and they called and asked for services, what would you guys do?
We would refer them to their closest option. There's families that call seeking services all the time for maybe a patient who's outside of our profile. For example, they're calling for a 12, 13, 45-year-old. All of our centers are equipped with resources to be able to refer these families to the most appropriate service based off of their funder. So it's not us or bust. We'll always give them another option.
Thank you very much. I really appreciate that. That's all I have, Madam Chair.
Thanks, James. Any other questions from the board? Hearing none, thank you very much for your testimony. It looks like the last person we have on deck for Action Behavior Centers is Audrey McIntyre. Are you in the audience, Audrey?
I am.
Good morning.
Good morning. Thank you for the time.
You bet. 2 minutes on the clock.
Perfect. My name is Audrey McIntyre. I'm the Vice President of Colorado with Action Behavior Centers. I'm also a proud resident of Weld County, Colorado, and a mother myself. My colleague Brian Davey earlier alluded to a crisis in 2023 that we experienced not even 3 years ago. Families across our communities left scrambling when several significantly sized providers were forced to leave due to financial strain created by the state's policy decisions. The consequences for children were profound. Many went months without therapy they relied on, leading to regression in skills, language, and independence. Families watched the progress they had fought so hard for slip away, and many lost hope as the providers who remained, including many of us in this room, tried to stretch already thin resources to support as many children as possible. We cannot assume that if this rule moves forward, our field will be able to recover or rebuild the safety net for families as we did in 2023. The staffing strain on providers and the hardship and heartbreak for our families may simply be too great to overcome. As both a professional and a parent, I can tell you firsthand, there's no more helpless feeling than knowing what your child needs and being denied access because of policy decisions made without foresight or empathy. That's my piece. I do want to provide some clarifying points on some of the things that you had asked Ryan as well. he had initially stated that only 30% of our patient population is Medicaid. It's actually the opposite. 70% of our patient population is Medicaid and 30% are commercially funded. You asked a question about training costs. The labor cost alone to train a new technician is anywhere from $2,000 to $4,000. That doesn't account for training materials, the cost to provide the trainer, the facility that the training occurs in, and any other resource or source that's financial source that's necessary to move that person through training. So I just wanted to be able to provide some clarity on that for you.
Thank you very much. We appreciate the clarification. Do we have any questions from the board?
Madam Chair, this is Cassie Littler.
Thanks, Cassie. Go ahead.
I just was wondering, and maybe you don't know the answer to this, but how many testing sites are there in Colorado for RBCs?
That's a good question. I don't know how many testing. Oh, there are two. Perfect. The clinicians in this room know. There are two. And the timeline to see for an exam varies based on seasonality and time of year. So that's also a potential delay in someone being able to sit for the certification exam.
Thank you.
Yeah, of course.
Any other questions from the board? Thank you very much. Okay, that is everybody from Action Behavior Centers team. Thank you so much for bringing so much of y'all out here to share with us how this will affect you. It really does matter to us. Okay, so I am working off of a copy of a spreadsheet and I cannot extend my cell. So I cannot read this person's full name and I apologize for that. So the next person I have up for testimony is with Behavior Span. And Nicole, I can see your first name, but not your entire last name on, there it is. Somebody, oh, thank you, Mr. Sykes. Nicole de Lima Liatao. Did I make it worse? Are you with us this morning?
We do not see a poll.
Do we have anybody in the studio audience? All righty, I guess what we'll do, since we have so much going on here, is if she happens to surface, Kelly, if you could give me a tap on the shoulder and we'll come back to her. Otherwise, we're going to go on to our next person. And now we get to speak with Mr. Bryce. Hi, Bryce Rafferty. Good morning. You have 2 minutes.
Oh, can you hear me?
I can.
Thank you, Chair Carroll, members of the board. Bryce Rafferty from CCDC. CCDC supports swift adoption of the clear, uniform credentialing and supervision standards so that our kids receive safe, high-quality care, and so Colorado protects federal matching funds. This is an issue of public safety and should be addressed accordingly. The facts do show that federal reviewers flagged gaps in training, supervision, and documentation among surveyed providers. And yes, that puts us at risk for disallowances of federal funds and massive repayments. Other states have faced similar predicaments. Compliance must be restored with 3 points of emphasis. First, credentialing and safety first. Establish one statewide set of provider qualifications, supervision, and documentation. Clarity, give providers a practical implementation route and technical assistance so compliance is achievable. And fairness and accountability. HCPF should clearly communicate with all affected parties, including families, and commit to publishing a readily available dashboard or data source showing metrics paired with targeted provider support. But HCPF should learn from this and do what's necessary to avoid future issues by stepping back and reassessing both the numbers and what kinds of transparent, readily available, well-communicated corrective actions should be taken so that we have a truly sustainable regulatory framework going forward across this and the entire Medicaid system. This situation reflects larger systemic cracks in HCPF's program administration, oversight, contractual enforcement, stakeholder rulemaking, transparency, and communication. Remedial measures here must inform a systemic regulatory and administrative overhaul that prevents repetition. More audits and potential emergency compliance measures don't just risk federal funds, but increased federal scrutiny and damaging ripple effects that pose serious risk to the structural integrity of Colorado's most valuable safety net programs. Finally, this rule fits the bigger picture. HCPF's Medicaid Sustainability and LTSS strategy is to manage trend drivers and maximize federal funds to avoid blunt cuts. Getting this right, protecting the existing federal match on the behavioral side, protects the enhanced match on the LTSS side. That's coherent, sustainable policy. Thank you so much for your time, and I will yield because I know there's a long line behind me.
Bless your heart, Bryce. Thank you so much. Do we have any questions for Bryce this morning? Hearing none. Thank you, sir. Always a pleasure to hear from you. The next person on my list. Yes?
I just wondered if you could give us an update of how many more people are on the list. Just because I have clinic at 1:30.
Well, that is kind of a vague question, to be honest with you, because a lot of them, I've got several that are also, again, parts of organizations where they have signed up 15 to 20 people to testify.
Okay.
So
No problem.
my hope is that those will go kind of similarly to how Action Behavior Centers went, maybe even more so, because I am definitely going to tighten the reins on people being repetitive. So if we were to count right now, I've got 3, 6, 9, 12, 15, 18, 21, 24, 27 to go.
Thank you. Please continue.
I'm doing the best I can for you. I swear I am. All righty. The next person I have on my list is Emily Ice. Emily, I do notice that you presented us with written testimony. We have read all of the written testimony. Did you have anything else to add to that, or can we just add you as a +1 as being present for testimony?
Madam President, this is Chris Seitz. I have just been checking with Kelly, and I believe Emily, Emily Ice is right there, Kelly. We are unmuting.
Good morning, Emily.
Hello, can you hear me?
I can. We are going to put 2 minutes on the clock. Oh, actually, let me ask you first. I see that we received written testimony from you. We have read it in its entirety. We do have 27 more people in line. Did you have something additionally to add to your written testimony? Or can I please just thank you for coming and reiterating what is in the contents of your letter?
I do have potentially I do have some additional comments if I could.
Very good. We're going to put 2 minutes on the clock and I'm going to be listening closely.
All right, sounds good. My statement, I'll make it brief. My statement is this, that HCPF has indicated that we could push this off to February 1st. We know that there's some questions that have been asked from CMS. The OIG audit has not been published, and those things would give us some clarity around the actual ability to provide for a rolling grace period. Additionally, we have been running this benefit as it has been in status for quite a while. And my statement would be that the situation does not meet the criteria for an emergency. Uncredentialed practice has occurred since the benefit was implemented, and the department has already demonstrated delay for this change during the rule drafting. And as their legal counsel has noted, any financial exposure from past claims or the audit cannot be corrected through future emergency rules. So I would ask that this not be addressed immediately, that we table it, we get the information from CMS, we get the information from the OIG audit, and then we address the ability to be able to do a rolling grace period at that point. Thank you.
Thank you very much. I would like to reiterate on the rolling certification issue that is not going to be addressed on this emergency rule. That is certainly something that we look at and talk about outside of emergency rule processing. I am going to ask people to hold on to your feelings about rolling certification. It is not something that we're talking about today. And in the interest of time, we just need to table that until we were at a position where we're actually discussing the final rule. We are all in agreement that that is not going to happen in emergency rulemaking today. Thank you so much. Do we have any other questions from the board?
Madam President, this is Rachel Entrekin, not the board, but I would like to make a record very briefly, if I may.
I will let you.
Thank you. I do just want to make a record that we have looked at the emergency rulemaking requirements very, very closely. And this absolutely does fit the definition of an emergency in a year where our budget is very constrained. And we are looking at the possibility of continuing to spend money in a way that could cause future liability. We cannot wait. Thank you.
Thank you, Rachel. Do we have any other comments from the room? Thank you very much, Emily. We appreciate you very much and you taking the time and being patient to chat with us today.
Thank you.
You betcha. The next person I have on my list is Jennifer Miles with Frontline Public Affairs. Jennifer, are you in the room or on the line?
Jennifer is coming to the table.
Come have a seat at our table.
Thank you.
Good morning, Jennifer.
Jennifer,
You have 2 minutes on the clock.
Okay, thank you. My name is Jennifer Miles and I'm here representing BIC, the Behavioral Intervention Certification Council. It's good to be in front of you here today. I used to come to the Medical Services Board a lot. It's good to see some of you I've known for years and good to meet some of the rest of you. As noted, I'm representing BIC, which is one of the certifying bodies for behavior technicians. We administer the Board Certified Autism Technician or BCAT certification. We want to thank the department for your collaboration and working with stakeholders, and specifically for including the BCAT as one of the 3 types of certifications that will be allowed in Colorado. I did want to note the term RBT is being thrown around a lot today. It is just one of the 3 certifications that are allowed. Behavior technician is the more common umbrella term that's I did want to note that while the department has communicated for the last 5 to 6 months, as has been stated about this new change, the communication that 3 different types of certifications would be allowed didn't actually go out till October 31st. And so providers have been working diligently to get their current staff certified, as you've heard. It does take some time, and some of that timeline is not in control of the providers. You've heard that some as well. So given both this timeline and the new information provided on October 31 that 3 types of certifications would be allowed, we greatly appreciate the consideration of extending the deadline to February 1st. We'll encourage you to support that change today. We do hope HCDF continues to consider a rolling grace period for new hires for all the things that you have heard today about why that's important. Of course, that would be while working towards certification and under direct supervision of appropriate staff during that grace period. But I do understand that will be addressed today. Thank you, and I'd be happy to answer any questions.
Thank you, Jennifer. Do we have any questions from the board?
This is Dr. Amanda Shilskip. One quick question. At your center or at the centers that you oversee, for example, how far out are your testing scheduled right now? Does that make sense? Like if I wanted to sign up for a test today, I do so, how long would I have to wait until I could sit for an exam?
It depends a little. It can take from 4 to 6 weeks generally. However, BIC does do remote testing and authorizes remote sites. So I know you heard RBTs have 2 testing sites around the state. I think we do have more available testing sites because of that remote testing technology and capability.
Okay. Thank you.
But it does take time.
Do I have any other questions from the board? Thank you, Jennifer. We appreciate you taking the time today. The next person I have up on my list is Nicholas McDaniel.
Oh, Madam President, this is Chris Sykes. Nicholas McDaniel was testifying on Rule 8.
I apologize.
Okay.
All right. Yay, one more down. The next person I have on my list is David Hughes, and it looks like he also provided written testimony. David, are you around and about? Hi, David. In the interest of time, I do see that you have given us written testimony, and we have all taken the time to read all of our public testimony. Did you have something in addition to add, or can we just submit your letter as record and move forward with the amount of people that we still have to testify?
Yes, given the length of the line, I'm comfortable ceding my time.
I appreciate you very much, David. Thank you so, so much. The next person on my list is JJ from Play to Learn Therapies.
Hello, thank you very much. I do have a question or a point of clarification that I'd like to ask before my statement, if that's possible, Madam Chair.
Sure.
Why are we not discussing the rolling period of certification today? Why would it only be available for discussion at the final order or final rule?
My pleasure to explain that to you. This is an emergency rule. This rule only lasts 120 days were it to be approved. Emergency rules are generally put in place to deal with, as it says, an emergent situation. And the act of the rolling certifications is not something that is written in the emergency rule. It is something that would be provided in the official rule were this to move forward. Emergency rules only stay in place for 120 days if approved.
Okay, so I do understand that. However, we just talked about a modification or an amendment earlier to the written rule as it is, based on comments or concerns. I don't understand why comments or concerns on this topic are forbidden for discussion.
It's not that they're forbidden. It's that they are not being included in the emergency rule. It will be part of the stakeholder process when we get to work on the final rule that will be approved and become final rule.
And yet it'll be in effect at least indefinitely until then.
It will be in effect for a total of 120 days if we choose to approve it today. We are also discussing within our rule, as you heard within our discussions, we are discussing that not going into effect until February 1st. And yes, that is something as a board that we can adjust. We cannot write an entire rule, certainly not within the space that we're in here. We all are in, I can speak for myself. I would like to see more about this ruling as we go. I just got a note from the people who do math better than me. And this emergency rule will last until the 11th of April. Oh, I'm seeing 13, 11, 12, somewhere in the middle of April.
All right, very good. Well, then I will.
You know what happens when you get too many chefs in the kitchen? You know what I'm saying?
I do.
Mid-April. Does that help you?
Not particularly, but I understand the point, and I will concede it. And I just want to say thank you for the time and opportunity to speak here. My name is JJ Gorsuch. I'm the acting COO of Play to Learn Therapies. We're a small, locally based, woman-owned agency here that's hyper-focused on the quality of care. Like others that have spoken, very supportive of anything that is increasing the quality of care, including the certification requirements. However, we think that as written, this rule does not take into effect all of the feedback that's been given about needing to have a training period, a rolling grace period for new hires in order to make sure that that certification is done to the highest quality possible. It will affect the access to care. It will affect the quality of care. And it seems that it is actually irresponsible to proceed as discussed earlier without the clarification from CMS. I do have a question about whether or not the question posed to CMS is for paying for technician services delivered while that person is in a training or certification process, or if it's specific to paying for services for uncertified technicians. You'll get two very different answers depending upon the context of the question. I also did want to make the clarification that we're not talking about paying for training, as was alluded to in one of the questions. We're talking about paying for technician services that were delivered while the person is in a certification process. We're opposed to the way the rule is written currently. We would suggest a simple amendment to the rule would be appropriate even now. I'll cede the rest of my time, and thank you very much for all your interest.
Thank you so much, JJ. Do we have any questions from the department? I'm sorry, from the board or the department.
Hi, this is Cassie Butler. I just wondered if you could mention a little bit about how many RBTs are certified with your company, how many are working towards certification, and how much Medicaid you take in your organization.
Yeah, great question. All of our technicians are certified who have started more than 2 months ago. That has been our practice going back in history. That would be our practice continuing to go forward. It does take time to certify them. We can rush it, but we have noticed that when we do, first of all, we can only rush it so much. And second of all, it actually does impact the quality of their training versus interspersing it with on-the-job training. We are talking about entry-level tech positions, and as mentioned before, nobody comes with an RBT certification. Yes, there are programs that are now starting up to build these kind of certification programs, but frankly, they're at the community college level. We only hire college graduates into this position because, again, of our hyper focus on quality. We believe it actually raises the bar quite a bit. So I think that answers one question. About almost 80% of our clients have Medicaid, either as primary or secondary. And I think that answers the other question. Actually, was there any other question there that you wanted to answer?
No, thank you.
Do I have any other questions from the board? Thank you so much for your time today, JJ. We appreciate you.
Thank you.
The next person I have on my list is Lynn Truel with 7 Dimensions. Are you with us, Lynn? Are we seeing her out in the participant area, Chris?
This is Chris Sykes. I am not seeing Lynn in the room. See if she's online. Do not see Lynn online either.
All righty, Lynn, if you're somewhere out there in the peanut gallery, please reach out to the host so that he can help you out and we'll come back to you. The next person on my list, again, I only have half of your name because of how this looks, but I've also got from 7 Dimensions Behavior, Rebecca. I see a thumbs up.
Yes.
Oh, woohoo. Hi, Rebecca. Good morning. Afternoon.
Yeah, good afternoon now.
I do see, Rebecca, that you did provide public written testimony to us. We have read that thoroughly. Did you have something you needed to add to that?
I sure do.
All righty, we'll give you 2 minutes on the clock.
Great, thank you. Hello, everyone. I'm here on behalf of 7 Dimensions. We are a small, local only Colorado provider, and I'm also the president of CWABA, our state association for ABA providers. A quick data point for y'all, over 98% of certificants in the state are RBTs, which is why you hear us focusing on that. I wanted to clarify some misinformation shared today. My company was part of the OIG audit, and I never heard from HCPF about this credentialing requirement until the July 31st memo. It was indicated we were contacted prior, not accurate. Providers immediately began working toward compliance, and as you see, we've presented data showing we've created 1,000 new RBTs in just 4.5 months, proof that this is not a quick or easy process. The credentialing timelines being referenced have ignored key steps, which include the passing of a hands-on test before the written exam, waiting for the test approval, securing the available test date. Data from a 100 provider survey shows that it's taking upwards of 18 weeks to credential newly hired staff. This data was shared with HCPF, but not presented today, which is concerning. In regards to the OIG conflicting information, it's my opinion that this would be irresponsible to move forward with a rule without confirmation of the written information providers have received from OIG, providing the clarification that credentialing grace periods are solely in the state's control. I'm curious, has HCPF shared written proof of communication with the OIG that has gone unanswered? because it would stand to reason that if providers can get a response within 48 hours, HCPF would likely be afforded the same courtesy. Because neither HCPF nor OIG has identified any applicable federal law requiring the certification of behavior technicians, it's completely unclear as to what basis OIG could plausibly seek to recover money on that basis. To the contrary, the fact that OIG's audit of Wisconsin did not identify certification as an overpayment concern suggests exactly the opposite. HCPF's claims of a potential overpayment issue on this basis do not make sense, and if they feel CMS approval is necessary, then they should wait to receive feedback from CMS prior to implementing the rule.
That's your time, Rebecca. Thank you so much for sharing with us today. Do I have any questions or comments from the board or the department? Hearing none. Thank you so much, Rebecca. We appreciate you taking your time today. All right, I am on to SOAR Autism Center. I have got a whole slew of you guys signed up to testify. Was there anybody in particular from that group that wants to go first?
Yes, hi, Madam President. My name is Ian Goldstein. I'm co-founder and CEO of SOAR. I propose I start, and then we can do a similar step as Action Behavior Centers to just pick.
That is my plan, sir.
Okay, great. Thank you so much for having me here today. My name is Ian Goldstein. I'm a physician by background. I have an MD, MPH. I'm also a dad of a child with autism, and so come here from both professional and personal context. We really appreciate you hearing us today. I wanted to start answering your question around what we're talking about. Medical students is the wrong example. Medical assistants are the right example. When you go to your pediatrician's clinic, and you deliver a vaccine and your medical assistant gives the vaccine, that person is not credentialed under Colorado Medicaid, yet you're able to bill for those services. We're simply asking for the same type of requirement that's allowed in many other parts of the Colorado Medicaid program. Medical assistants, pharmacy technicians, dialysis providers, mammography technicians. Why are we allowed to screen for breast cancer? Why are we allowed to provide life-saving dialysis therapy? Why are you allowed to give a vaccine in your center, but we're not allowed to do the same thing in ours? It doesn't make any sense. At the end of the day, this is about access. Do you see how much red and orange is on that slide? This is on Monday, services stop for children, young children. This is a 2-year-old who is nonverbal. This is a 5-year-old who is in diapers and is not potty trained. And we are sitting here around the table removing services from them on Monday. Colorado Medicaid has a discretion to provide a grace period. There is no federal requirement for an RBT. We have reached out to the OIG. They have told us that there is no requirement for an RBT, and it's at the state's discretion. The state's discretion is this meeting. Please add the rolling grace period. It is impossible to do this. Otherwise, every single red and orange area there is going to stop on Monday. When we are talking about children, the obligation is on the state to provide the actual citation. What part of the CMS code requires an RBT certification? Where in the OIG audit does it come from? You have not provided it for us. You are losing access to children on Monday. Where is it? This is the last opportunity. You all
I'm
are
sorry, Ian. Ian, while I love your Ian, may I have order in the room, please? Ian, I so appreciate you, but we do have to stay to our 2-minute times on these. And if I can please have a response from the department or from the board.
Yeah, Madam Chair, this is Dr. Schlinsky. I appreciate that. I think that's a very good comment, and you're correct. It is not the same as a medical student, so I appreciate your feedback. I'd like to just take a moment to address the temperature in the room right now for a minute, okay? We are all here as volunteers because we care about Medicaid recipients in Colorado. And I just want to emphasize that again, okay? As a person who serves a population of 70% Medicaid recipients in her clinic and works in a nonprofit, I truly understand the difficulty with margins. All right. So I'm just saying that because I think that if we are getting at this in a combative way, we're probably not serving the kids in Colorado either. Can I just continue? So I think that my comment is, Madam Chair, it seems like the recurrent question comes back to and concern this rolling, this request for the rolling grace period. I'm not sure if there's another member of the board or the department who feels that they can address this concern for the folks in the room, because just based on my experience as a pediatrician, as a volunteer on this board, I want to make sure that we are doing within what we are bound to do and what we, like what our limitations are as a board. But I also want to explain that in a satisfactory way, because I think this is a very real concern. I just recognize that I don't have all the knowledge on that, on what is our responsibility. So, thank you.
Rachel,
Madam
may I
Chair.
be for some help with this?
Yeah, Madam Chair, actually, I was wondering if I could add to that, if that's okay. Is that okay?
Well,
I
I'd
mean,
kind of
just-
like to get a feel. There was a specific question answered, and I'd sure love to get her question answered. And I was going to reach out to Rachel on that one. Because I feel like clearly I am not explaining well how emergency rule versus the final rule would work, and with rolling and everything else. So I'm wondering, Rachel, can you jump on and kind of explain that difference again, since I am doing it poorly?
Thank you, Madam President. Rachel Intrican. I am in the process of phoning a friend right now. The one thing that I can say is we are doing the very best we can. I really appreciate the passion. I come to work every day because I am also passionate about serving our Medicaid population. That's the only reason I have this job, and it's my favorite job ever. And it's not because I like saying no. So I do just really, really want to bring that home for folks. We are not your enemy. We are here in cooperation with you, and we are trying to get to the right answer. I just don't think we have the data we need to give you a definitive answer about rolling grace periods today in a way that would be responsible to all of our population. So that said, I'm going to pass it over to Justine Pierce, who is on our Attorney General team, and she is also going to try to take a crack at your question.
Hi there, Madam President. This is Justine Pierce. I work at the Attorney General's office representing, I'm here on behalf of Jennifer Weaver, who normally sits with you guys today. So can I get some clarification on exactly what your question is? Are you asking if the board has the authority to, I heard, what's the board's role around addressing the request for a rolling grace period? Is that the question?
This is Dr. Jashinsky. Yes, Justine, I think we're being asked repeatedly by folks, and understandably, to address the concern of the rolling grace period. My concern is that was not within the scope of what was laid out today. So if you could please provide some clarity on that. On what we can and cannot, do as a board, and that might be helpful for not only just us, but the folks here today.
So are you asking if the board would have the authority to write a rolling grace period into the rule?
I guess I'm asking whether discussing rolling grace periods, as it is not part of the rule put forward today, is within the scope of our discussion. Because my understanding is that our role is to look at this rule as given to us and determine what to do with it, not whether to add to it. If this rule was to be significantly amended, my understanding is that it would have to be presented at the next Medical Services Board meeting for review. But I apologize if I'm not understanding that correct.
No, I think the way that I was hearing a lot of the commentary today about asking for a rolling grace period was essentially a request to reject this rule because it does not have a rolling grace period. And I think that is certainly commentary that this board can consider. Does that answer your question?
That helps, yeah.
Go ahead, James.
Thank you, Madam Chair. I would just like to reiterate, thank you for the passion. I get it. As somebody, if it was a rule around the world that I work in, I would come with the same passion. So I absolutely appreciate that. And I appreciate your comment that we really all do. It comes down to serving people. And that's what everyone at this table does. We serve people. And that's what everyone in this room is trying to do. You're fighting for your ability to serve people, and we get that. The challenge we have before us today is we have a seesaw. And in that seesaw, we have to balance the needs of this room with all the other needs. And if we get it wrong, like, the mistake could be huge. What I like about what I'm hearing today is that we have the opportunity to kick the can down the road a little ways and to create space to get it right. And I my gut tells me that when you're not sure right now what to do, sometimes the best thing to do is throw it out of bounds and live another down. And I'm feeling like if we can do the approve it, set it for February, that gives us between now and February to get some of these answers that we need, that we just don't have today. And I'm not feeling like I have the information to do more than that. And so I guess, am I spot on with that assessment? First of all, is that that if we approve this today with the extension to February, that gives us to February to get this right, and that revisions can be made and we'll have additional information by then?
Madam President, Rachel Entrican for the department. That is why I am hoping that the board will give us an extension of the effective date to February 1st. I am wanting more time to be able to make sure we get this right. And I'm trying to balance that with the financial risks that we've already talked about today. So which is why I would be deeply uncomfortable kicking the can down the road too much farther.
It just a follow. If we were to do that, do you guys trust us enough to get the right information and input from everyone else to make the right choice?
Can I respond?
Absolutely.
First off, I apologize if I brought too much passion. It really comes from being a dad, being a provider, and honestly serving young kids. We're trying to do right by kids. I would say our preference would be if the department is willing to wait until February 1st, I believe there's a medical services board meeting in January. Correct me if I'm wrong on that. Can we just kick to the medical services board meeting in January, evaluate it over the next 30 days or however long it takes, and have the full totality of information? It's the on Monday aspect of it, with this piece still being up in the air. And I just want to emphasize the other area why we feel frustration is we've been giving this feedback since July. We're giving the same feedback. We gave the feedback in July, and it's not being addressed here in the rule. And so we feel like we keep saying the same thing and it's not being heard. And you all are the last opportunity to actually hear it. We don't have anyone else. You're the last one left. And we just want someone to hear us.
May I address that, Madam President, or respond and ask a follow-up question? Sorry, Dr. Schlinsky, for the record. So this is the concern around the rolling grace period, correct?
It's the only
and that's
thing.
the one that you've been bringing up.
Yeah.
So thank you. I guess my question is, and I think I asked a similar question earlier, but I just want to get clarity from Rachel and from maybe you, Justine, is my very little understanding of how the purse is controlled in government, right? That's the thing. If we were to make a decision on something like rolling certification, which would have a budgetary impact in that I recognize there are a lot of ifs, but if the services provided during that rolling period that a behavioral technician provides do not get matching funds from the federal government, then those services would entirely be paid for by the state. In which case, my understanding is that might have to be a decision by those who control the purse of the state as to whether or not to allocate funds for that. Is that, and I'm just trying to make sure I understand how state decisions on funds get made.
So, sorry, Madam President, Rachel Entrican, I am going to put my finance director's hat on virtually to see if I can get this right. So, yes, and there is a set budget that the General Assembly gives to all state agencies every year, and it's typically planned for 2 years in advance. So the budget is already set for this year. We are looking at budget decisions that will impact going forward, starting in 2027 now. General Assembly meets every year, and they consider both a long bill, which is sort of like all of the stuff that goes out to agencies, priorities, those kinds of things. And then there are separate bills that also get funded to varying degrees. So they may come earmarked with money. Typically speaking, Medicaid is a federal state partnership. And I know I'm explaining this at a really basic level, but just bear with me for a minute. It's a federal state partnership where the matching rate between federal and state in Colorado is set at 50-50. So we rely on those federal dollars to make up for where we could not as a state support an entire program only with state tax dollars. So when we have an opportunity to consider whether or not we want to or can pay for state only funded programs, that's really not our decision.
Can I just make a quick clarification? This is Dr. Goldstein with SOAR. If the situation you were saying is true, we actually would support that. Like if the state had to pay 100% for these services, we would not be arguing this. That's not our argument. Our argument is that we don't agree that there's no match for the post-training pre-credential period. There is no federal rule for that. That's not true. That's our point. That's what we want clarification on. Look at Missouri. Missouri has a state plan amendment that CMS has approved that has a rolling grace period and that they pay for. Why can't we do that here? And so we're not saying that we want the state to pay for 100% in this time period of 30 days or 60 days. We're saying there is no rule. We're saying the match does apply there. And we're simply asking for complete clarification on that instead of ambiguity. Does that make sense?
Yes, that helps. So,
Oh, this is Kathy Littler. I was just wondering if you could comment on how state plan amendment works and how that could get done, right? Because that's what you're asking.
So, Madam President, Rachel Entrican for the department. So state plan amendments are, wow, I am not the right person to talk about this, but I can talk about it at a very high level. He is on the line? Yeah. Russ, do you want to, can I phone a friend?
Sure.
Hey, Russ Ziegler.
Russ Ziegler, can you explain to our
Russ,
medical services?
do you want to phone Russ Ziegler? Yeah, let's bring him up. Where are you at, Russ?
He is muted and off camera. Russ.
Russ. Russ, I can see your name, but can't hear or see you. Are you out there? Oh, it looks like he's.
While we're waiting for. Okay, we're reaching out, but while we don't have him, I will go ahead and start if that's okay, Madam President.
Please.
Okay, great. So state plan amendments, there is a state plan, which is Colorado state plan is about 1,200 pages long, and it is essentially the contract between HCPF as the single state Medicaid agency and the Centers for Medicare and Medicaid Services. It is how we ask for permission to structure programs, sometimes to set payment rates, those kinds of things. It depends. But a state plan amendment typically takes a number of months. There is a back and forth process between the state and CMS. And CMS, we ask for approval of a state plan amendment by a date certain. And then typically if that approval happens within the same quarter, we get that approval and it applies to the. I'm not sure if that answers your question though, Dr. Littler, in terms of how state plan amendments work.
I appreciate this, Kathy Littler. Thank you so much for that. I guess ultimately my question is how likely is it for the federal government to grant us a state plan amendment based on this question?
Yeah. Thank you, Dr. Littler. Rachel Entrican again. It depends. So I don't disagree that there is not a federal requirement for certification of technicians. You are absolutely right. I have also not been able to find one and no one else has either. That does not change the fact that we have an OIG finding that currently tells us that we cannot cover uncredentialed technicians. And that gray area is where we are living right now. You're uncomfortable with it, so am I. So I don't know. And it really depends on the type of policy and the administration and a number of things. And so I don't have a good answer to either of these concerns. Thank you.
Russ is briefly on camera.
Did you want more of a, our state plan amendment guy is on.
If he has any additional.
The Russ Ziegler of it all. Go ahead, Russ.
Love this guy.
We do love this guy. We have no
Good.
sound for you though, Russ. Standing by.
JK, yeah, at 125. We still.
Yeah. Man, and Russ is like the expert at all of this. This scares me. Could we try to have Mr. Ziegler hop off and rejoin, and Kelly will watch for him very diligently?
Yes.
Excellent.
Madam Chair, while
Sir.
we're waiting for Russ to come back on, I was wondering if I could just ask one more point of clarification.
Please do.
So again, going back to kind of what we were talking about, we're just not sure. We're living in that gray. And what this allows us to do is to show that we are making good faith effort in moving forward while still providing the space for that information to come in and to get it right. And I don't know that I know that I couldn't support this if it was taking effect Monday. I couldn't do that. I know where I'm at. Like, if it's taking effect 2 months from now and it gives us a little breathing room, I can lay my head down tonight and sleep, knowing that these services are still available and we have time to get the information we need. If you are correct, and I don't know if you are or aren't, I have no reason to believe that you're not. If you are correct, by January, hopefully, we're gonna know. And I have faith in the fact that what I've seen from HCPF is they will take that information and do what's best to do the most good for the most people. And that's what we're trying to do today, is do the most good for the most people. What I've consistently found in compromise is that no one gets everything they want, but we all get as much of what we want or what we need to make it worthwhile to keep moving forward. That's not ideal. I get it.
Madam Chair, may I ask one or add to James's comment, one additional comment question? In this, let's say this still has to take effect come February 1st.
Testing.
But
Okay.
at that point, can we also continue working towards a state amendment or other adjustments to address the rolling grace period so that then we don't have to continue under the current policy of not having reimbursement? You see what I'm saying? Like, we could change our policy based on the feedback we get today or work towards a change in the future, right? I mean, it's nothing holds this in stone.
No, absolutely correct. Even passing this emergency rule imperfectly does not mean that the final rule will look the same, right? The emergency rule gives us a position to put something in place while we work for what we're really looking for.
Thank you.
Let's see here. I see Russ Ziegler. Say hello to me.
Hello, can everyone hear me?
Hi, Russ.
There we go. Sorry about that. We've been having some Friday.
The floor, my friend.
All right. Well, I got a ping that we just need kind of an overview of the state plan amendment process. I'll give my 10,000 foot view, and then if you need clarification from there, just let me know. So everything is driven by the effective date. So I'll just use an example of like January 1, 2026. If we had a SPA that had to be effective on that date, the process would be, well, and it depends on if it impacts budgets. So if it changes any of our budget, whether we're spending more or less federal money, and it's changing a payment or payment methodology. Let's assume for this example that we are, that changes the public noticing process. So let's say we've got a SPA that needs to be effective 1/1/26. It changes payment methodology. Essentially, what that would look like is that would have to be submitted within or prior to the first quarter of 2026. So because the effective date occurs in first quarter 2026, it would have to be submitted no later than March 31st, 2026. It can be submitted prior to that, but it cannot be submitted later than the last day of that calendar quarter. As far as noticing is concerned, there's two types of notice we have to do. First is a public notice. Again, this is for payment changes. And that has to be done prior to the effective date. So in that case, we would have to get that public notice out before January 1 of 2026. And we have two opportunities to do that. Generally, it's the 10th and the 25th, which is when the Colorado Register publishes. That's a whole other issue, though. And then moving on to the tribal consult, that every SPA requires that. And so we have to send a notification to the tribes saying this is the state plan amendment we're proposing to do, give them 30 days to comment, and then we can submit the SPA. So that's one factor we always have to keep in mind, because if we don't do that more than 31 days before the end of that quarter, and we wait too long, we actually can't submit that SPA because we have to give the tribes at least 30 days to comment. So let's say we did our public notice before 1/1/26. We did our tribal consult, so we have at least 30 days comment period for them before submittal. Then we submit the SPA to CMS. That process looks like they have 90 days to review that. And there's three things they can do. They can approve it without any questions, which pretty much never happens. They can deny it, which pretty much never happens. Or the third option is they can ask us questions. Informal questions, so via email, we can get those within the 90-day period, and we can respond to those via email. And that doesn't change their 90-day review period. And if I'm going into too much detail, please feel free to stop me, but this is my kind of elevator speech. And And we usually get lots of questions back and forth for CMS. So they'll send us emails asking for clarification on specific things. If it's just via email, we'll go back and forth. And it's very likely that it will be approved on that first 90-day period. So let's say we submitted it on like the last day of January, we would have until the end of April before CMS's review period closes. And we can go back and forth with them on informal email questions that whole time. And then they'll likely approve it on that 90-day. So if CMS gets to the end of that 90-day period, so let's say we're getting towards the end of April, and we haven't resolved all of their questions, they need more clarification, what they can do at that point to get more time is to submit a formal request for additional information. We call that an RAI. That officially ends their clock. They have to submit that within that 90-day period to get that additional time. And then the ball gets passed into our court. And then we have to take those formal questions and we have to reply to all of them. And we then have 90 days to do our response. And so their clock is paused. Once we submit our responses, again, that has to be a formal response on formal HCPUF letterhead, just like the formal request from them is on formal CMS letterhead. It's not via email. Once we submit our formal response, then CMS has an additional 90 days. So let's say, they get their REI to us at the end of April. We get our response back to them by the end of July within our 90-day period. And then they basically have until, what would that be, October, to then review our responses and decide if they're going to approve the SPA. So that's how the SPA process can get really drawn out. And I'll stop talking. If you want specifics about like how the state plan is structured, I can do that too. But that's the submittal and review process in hopefully not too much time.
Thank you. That answers my question.
Thanks, Russ. We appreciate you as always. While we have Mr. Ziegler on the line, is there anybody else on the board who has any questions for him? It was so kind of him to jump on.
One last question, Madam Chair. This is Cassie Littler.
You
Russ,
got
I don't know if comment on this or have any idea, but how common or likely in this current landscape is it that Colorado would be able to get a SPA approved within the next year to, for instance, get matching funds for behavioral technicians to draw down federal matching dollars?
I mean, within a year, I don't think that would be an issue. CMS, they want to get everything approved on the first clock. So if it's like a really thorny issue that's going to require a lot of back and forth, it may go to REI. But if it's a straightforward behavioral health SPA and it's just expanding provider types, we do stuff like that on a pretty regular basis. So I mean, without knowing all the specifics, I wouldn't say that would be an issue. But again, if it does go, if we do get a bunch of questions, we have to go back and forth. It could go to REI. But again, I wouldn't say that there's a huge red flag there as far as getting that approved within the next year.
Thank you.
Mm-hmm. No problem.
Any other questions for Mr. Ziegler, board? Russ, thank you for being part of our Phone the Friends network. We appreciate you.
No problem. Always happy to help. Let me know if you have any additional questions.
Appreciate you like always, friend. If I don't talk to you, have a good holiday.
No problem. Same to you. Same to everyone. Have a good one.
Yeah.
Goodbye.
I see you, James. I see you.
I was just saying Merry Christmas to Russ. That's all.
Gotcha.
Merry Christmas as well. Good to see everybody. Have a good one.
All righty. Do we have any other questions for, I think we're still talking to Dr. Goldstein. Is that correct?
Yes.
Sorry that took such a wide turn on you, sir, but thank you for creating the dialogue that you did. It really matters to us.
Yeah, thank you. So, Madam President, if there are no other questions for me, I propose that we just give back, in the interest of time, everyone else from SOAR, other than Will Martin, who I believe is speaking on behalf of COABA, assuming he's on the list, and then we can get back to the rest of SOAR, just in the interest of time.
Well, what I'm going to do, Dr. Goldstein, is how we plan to set this up is I am going to see if there is anybody from SOAR who has something new or different to add. And if not, I would be happy to just include their names on public record. We are getting into 1:40 in the afternoon for a meeting that is supposed to be done by noon. So the next person on my list is Allie Dillenberg. Allie, did you have something additional to add than what has already been discussed?
Nope, I'll cede my time.
I appreciate you. Thank you, Allie. The next person on my list is Samantha Smalley.
No, I cede my time, well.
I appreciate you. Daniel Spiegel.
See,
Thank you, sir. Ford Care.
I will cede my time as well.
Thank you, sir. Kyle Kissinger.
He had to leave.
Very good. We do appreciate that he tried. Please let him know. Jana Persky.
I cede my time.
Thank you, ma'am. Matthew Durst.
He had to leave.
All righty. And then the next person on my list is Emily Looney. I also see that she provided written testimony. Did you have anything to add to your written testimony or anything that's been mentioned, Emily?
Nothing further to add. Thank you all so much.
I appreciate you immensely, Emily. Thank you. Next person on my list is Ezra Jock. Did I mess that name up, Ezra? I'm sorry.
You're golden and I cede my time. Thank you.
Thank you so much. Appreciate you. How about Madison John?
I cede my time. Thank you.
Thank you so much. How about Will Martin?
Coming
forward.
It's coming.
Hi, everyone. My name is Will Martin. I'm a board certified behavior analyst. I work at SOAR, but I'm actually here representing the Colorado Association for Behavior Analysis. I'm a board member and the co-chair of their public policy committee, which is also a volunteer role. So thank you guys for also volunteering to the community.
Okay, did you have anything to add?
I do, and I'll keep it short and I'll try really hard not to repeat.
Okay.
Okay, great. I think for me, I agree with everything Dr. Goldstein and others have said. I think I need to better understand what we gain by voting today on a rule that goes into effect in February. What we potentially lose is instead of on Monday, these restrictive cuts going or loss of services going into place, it can happen on February 1st and be in place until April. We're essentially trusting the department, which has given us very little reason to trust them, that they are going to make this right in the next 30 to 60 days. Instead, I would prefer and urge you to vote no on this rule, kick it back to the department, have them do their homework, get enough information from the OIG and CMS to give you a complete rule with all of the information you need to make an informed vote. And then we revisit this once that's done. There's simply too many open questions for us right now to make an educated and informed vote. And the department has said that. We don't have all the information. If we can wait till February, why do we need to vote today? Can't we vote in January once we have the OIG report and we've heard from CMS? The department has told the provider community, we expect the report by the end of the year. So we should have it in a couple weeks. And so we should be able to see what the OIG says, hear back from CMS, and make an informed decision at that point. There's risk, even with the February 1st deadline, in implementing this rule as written today, and that risk is loss of services for kids. Thank you very much. I see the rest of my time.
Thank you, sir. Do we have any questions from the board, comments from the department? Thank you so much. I'm sorry, somebody talked.
Yes, Madam President, this is Rachel Entrican. I just wanted to thank you so much for your time and your comments. And I just have to reiterate again that we share your concerns. We are looking at this as what are the ripple effects across all of our programs, and that is a really hard place to be. So we're going to try and get information as soon as we can. Boy, would I prefer us to have a trusting relationship instead of one where I feel like the department has been working really hard to get to some kind of workable solution. And I'm disappointed to hear that you feel like we haven't done much to earn your trust yet. So hopefully we can continue to work together.
Thank you, Rachel. Any other comments from the board?
I have a this is Barry Martin. I have a question for Rachel.
Go ahead, Barry.
You probably answered this several times, but still I'd like to hear again, what is the what would be the downside of putting this off until January? Till our January MSB meeting?
Sorry, this is Chris Sykes. Dr. Martin, are you just saying to table this rule for a month and bring it back in January? I'm sorry, I'm just trying to get clarity on your question.
Yes, some of the commenters have asked, wouldn't that be better to get some more answers, and then bring back a rule that we have more answers to, rather than, and I'm not arguing that that's the right thing to do. I'm just, the previous speaker asked about that, and I'm wondering why it is that that would be a bad idea.
Yeah, Dr. Martin, thank you so much for your question. I think I would go back to what I have already said a couple of times, which is that by not taking action now, understanding that, we're trying to work with our providers, and in fact, we have kind of pushed this out several times by now. This has been going for about 6 or 7 months that we've been talking about this. And we're continuing to incur liability potentially to the federal government. That's a real concern. And continuing to have concerns around quality of care and safety. I think what I was hoping to work towards would be a vote today, and then continue to work with our stakeholders and the board to provide an update in January. So that's where I'm headed. But again, but the one thing I would ask is that if the board is leaning towards voting this down, I would prefer to table the rule. We've done a ton of work on this, and starting over from nothing would be really difficult.
Thank you.
James, I think you were next in line, yes?
Yes, the very question I was gonna ask. Thank you. Barry, you're amazing.
Am I allowed to respond, or is that okay?
I can't see who's speaking, I'm sorry.
It's Will Martin again. I was just curious if I could respond to something that Rachel said, if that would be acceptable.
I have some questions first, and since we are kind of past the public testimony, give me a minute. Let's see where we're at, okay?
Sounds good, thank you.
So I'm going to do a point of understanding with Rachel here while you all are listening. So it sounds to me like our choices on the table are vote yes or no, or that we have the option to request that the department add a clause that none of this happens till February 1st. Are those at this point the three things that we're looking on the table? And I put that out to both Rachel and the team, because I'm here vigorously making notes, but I want to read the room.
Yes, and if you're asking me, Madam President, I would say yes, and a third option would be tabling the rule and bringing it back.
And is that tabling something that happens by the department or by the board?
That's something that I will ask if the board is not comfortable voting on this today.
Right, because it is the department that has to table stuff, not us. Isn't that correct?
This is Chris Sykes. Not entirely. The board can say, we would like you to go and work on it some more.
So we can say that?
This is Chris Sykes. Yes, we can.
Okay. I guess I just need to open this up to my board real quick. David. Yes, you can go first, David.
Thank you. I have been diligently listening to the passion and going around and round in circles. And I'm so glad that our concept of polling, having the board, having staff just poll this until we get this critical data that nobody but the department's able to see, would probably be the most expedient thing. Because I am leaning towards asking the board not to even bring the motion, which would effectively kill it, or just voting no, because I don't have that critical piece of information that I feel I need in order to do my job appropriately.
Thank you. Is there anybody else from the board that would like to speak at this time?
This
Madam
is
Chair,
Barry.
this is James. Oh, go ahead, Barry.
I was just going to say, this is Barry Martin. I'm not sure how I would vote, but I still don't see any downside to tabling this and bringing it back in January because if we approve it today, it won't start until February. If we approve it in January, it could start in February. So I don't know that I can see what the downside is.
Any other comments from the board?
Yeah, it's still the words out of my mouth.
That was James McLaughlin.
Sorry, James, you're fine.
This is Laura Carroll. I actually tend to lean in exactly the same direction. If we're talking about it as a team, right? I would not have voted for this to stop on Monday. So I'm certainly glad that we had an intelligent conversation about that. That was just completely unacceptable to me. Beyond that, it's really a matter, board, I guess we really need to decide what we think here, because yes, if we vote it no, they got to start all over again. And I do think this is something that we really need to get reeled in and understand, because there does seem to be at minimum, a lack of understanding of what the definitions of what these services are, right? Because if there's nothing in the federal rules that explain it, if there's other states that are doing something different, I don't feel comfortable voting on this when I don't actually have all the answers either. So with the pool of our team that I have taken, and I want any one of you to jump all over me if I've got this wrong. But it sure seems to me that what we are requesting of the department at this time is to get the answer to the questions that all of us have, and then represent this next month with the understanding that we weren't going to put it through till February at this point anyway. I can only make that recommendation, and it is my hope that the department will accept it.
Madam President, this is Rachel Intrican, if I may.
Please.
Okay. I would like to request the board approve tabling this rule. After listening to the robust discussion, hearing the feedback from the board members just now, I understand that more work needs to be done on the rule. And hopefully by the time we bring this back to you, we will have the answers that people are looking for. The department commits to returning following additional work with your approval. So I'd like to table it for today.
May I have a motion?
This is James McLaughlin. I make a motion that we table this.
May I have a second for that motion? Thank you, David. All in favor, please say aye. Aye. Opposition? Abstentions? I see a hand, Tiny.
Not in opposition.
Okay. Don't do that to me, man. Just don't even. All righty, team. We have tabled Rule 9. Now we get to go back to other worky stuff. So remember way back earlier today when we had stuff that was on initial approval? Remember those rules back then, you guys? Rules 4 and 5? I probably should have asked this before we got into this mess, but does anybody have any feelings about consent agenda on items 4 or 5?
Put them on consent, please.
Excellent. Does anybody disagree with Mr. Pump? No. I like it. I like it. Mr. Sykes, will you please make that magic happen?
This is Chris Sykes, absolutely.
Wonderful. Yes.
Sorry, Madam Chair, just real quick, I wanted to ask one other point of clarification on number 9 before we go. I know it's tabled and I'm really happy with that. But I wanted to ask Ms. Intrican a question if I could.
Go ahead.
Quick,
just remember that you're the one keeping us here.
Fair enough.
It's all you. As long as you understand
It's MCM. You said there were three things that came out of the kind of the preliminary discussions with the OIG. This was one of the three. What were the other two?
I can give you high level. Yeah,
Okay.
and I did provide this a little bit earlier, but it was fast.
Yeah.
Madam President, Rachel Entrekin for the department. There were three general pots of findings. One was uncredentialed technicians. The second was failure to maintain records. The state bears the burden of proof in pulling down the federal funds from the Fed, which means that we also have to require providers to hold on to those records in case we get audited or they get audited. So there had been a failure to fully keep documents. So maybe a patient file with one piece of paper in it, for example. And then the third set of findings was related to the note-taking, the record keeping for each individual session being inadequate. That was part of the second one. Third one was billing for time that was not reimbursable. So when a patient was napping, when a patient was playing or eating, but the note just said something along the lines of Rachel was eating.
So like a parent inappropriate use of the service, trying to use the service for things that aren't specific to what the service is supposed to be used for.
Correct.
Got it.
Yeah.
And that could be a documentation thing, or it could be so correct. And the reason you guys
Tiny, I have to hang up in 3 minutes. So I'm gonna close this. And since you guys are both in the room, you're welcome to talk about this stuff. Whatever.
Fair enough, thank you.
No disrespect or anything. It's two in the end.
None taken.
All right.
Your job.
So I move that all rules adopted at this meeting of the Medical Services Board of the Colorado Department of Healthcare Policy and Financing meet the criteria of the State Administrative Procedure Act, which are incorporated by reference. May I have a second?
This is Amanda, I second.
Thank you, ma'am. All in favor?
Aye.
Aye. Anybody want to keep on with this? Wonderful. Y'all, I want to take a moment and thank you. Thank you so much. You guys make this job so easy. You are a remarkable team. Have a beautiful holiday, and I'll see you next year. Bye, everybody.
Bye.
Happy holidays.
Merry Christmas, Sheriff.